Paviaplay.it. Accende il tuo territorio.
Important seminars for doctors and pharmacists and students who want to look the future of clinical pharmacy. Anchoring the past makes no sense if the future makes work easier and cheaper, more effective and more efficient. It's very important to learn to work in an efficient team, particularly in specialistic wards such as internal medicine and geriatrics wards and emergency departments. Organized by Prof. Simona Collina, Dean of Pharmacy and CTF Courses, Prof. Giovanni Ricevuti, Teacher of Clinical Pharmacy at University of Pavia, with the collaboration of Department of Drug Science, School of Pharmacy, University of Pavia, Erasmus Office of School of Pharmacy, conferenza permanente dai direttori delle scuole di medicina di emergenza ed urgenza, conferenza permanente dai direttori delle scuole di specialità in farmacia ospedaliera, PhD in Biomedical Sciences, Harvey School of Medicine, University of Pavia, Master in Crisis Management in Healthcare, Emergency Medicine, Italian Society of Clinical Pharmacy. We will discuss the nuances of the modified approach to take with seniors and lead into the discussion of polypharmacy, geriatric syndromes and problems among geriatric patients in the ED.
Bisogna preparargliela di già sullo...
È già condivisa, no. La metto in una presentazione. Sì. Good morning, everyone. Thank you very much for your presence at this seminar. To all present on site at the Collegio Berromeo and people online. I'm very happy to introduce Professor Jennifer Cole from Harvard University and Massachusetts General Hospital, Boston, USA. She is a pharmacist involved in teaching and also coordination of didactical activity for residents in pharmacy at Massachusetts General Hospital and other hospitals from many universities in USA. And now she is in Italy with us to discuss a very interesting and new aspects for us, clinical pharmacy, in particular emergency clinical pharmacy. And she now will explain what is happening during a day for a clinical pharmacist. Thank you very much, Jenny.
Thank you. All right, here we are. All right, hello everyone. Can you hear me? Okay, awesome. Well, thank you all for coming. Like Giovanni said, this lecture will be what I love the most, which is pharmacist involvement in emergency medicine. My talk after this will be more kind of general about clinical pharmacy, but this one will focus on my role within the emergency department. So I do work in the emergency department at Massachusetts General Hospital among the physicians, and we'll kind of talk more about what our care team looks like in a few slides. But we do also have a residency program for pharmacists to specialize in emergency medicine, and I am the director for that as well. Okay. So this is kind of how I got to where I am today. So this is the roadmap to how to become an emergency medicine specialty pharmacist in the United States. So you first complete your middle school, elementary school, just like you do, and then our high school, which would be 4 years. And then you do have to do undergraduate or training at a college or university. I did 5 years because I just loved college so much. Typically it's 4 years. And you typically major in something like I did, like microbiology, biology. Some universities do have undergraduate majors of pre-pharmacy. That is becoming more rare just because they want you to get a more kind of well-rounded education before starting pharmacy school. So I got a bachelor's of science in microbiology from Arizona State University. And then I went on to pharmacy school. So pharmacy schools in the United States can be either 3 years or 4 years. The difference is if you go to a 3-year program, you don't get the summer between first and second year and second and third year off. Versus 4 years, you get those summers off to kind of explore different areas of pharmacy that you'd like to. And I'll tell you why in the next slide, why I think the 4-year schools are a little bit better, just because you do get the extra opportunity, and I'll show you what I did with mine. But I went to the University of California, San Francisco for my pharmacy school, which was 4 years long. I will say since I graduated, it has switched to a 3-year program, so those are becoming more popular just because students like to have a shorter time in school. Can you guys hear me? And then after you finish pharmacy school, if you'd like to be a clinical pharmacist or a pharmacist that works within a hospital, you would go to residency. So during your 4th year of pharmacy school, you would start applying to different residency programs, interviewing and getting accepted. So there's 2 years of residency. You don't need to do 2 years. You can just do the first year. If you want to, say, work in like the central pharmacy and not specialize in a patient population. But then if you do want to specialize, say specialize in emergency medicine, you'd have to do a 2nd year residency. And I did find out at dinner last night that it was shocking that these are paid. So you do get paid for your 2 years of residency. And it's not bad pay. So it's definitely livable. So that is kind of how I got to where I am. But why did I choose emergency medicine? So the summer between my 2nd and 3rd year of pharmacy school, I went to Tanzania and I worked in their emergency medicine department at Muhimbili National Hospital, which is the national hospital in Dar es Salaam. And there I worked on a research project. They were looking at the safety of ketamine, which is a sedative used during sedations. Unfortunately, there is mainly for pediatric burn patients, but they didn't have any of the equipment to monitor patients' vital signs or respiratory status. And so while the patients were sedated, I took their vital signs and respiratory status every 5 minutes manually to make sure they were all okay. And this did end up getting published. But so I spent 4 months at this hospital and touring around Africa, and I just fell in love with the fast pace of the emergency department, how well integrated pharmacists were. There weren't pharmacists there in the emergency department, but when I got there, they were just so excited to talk more about medications. And ever since then, I just knew that this was the path that I was going to take. But typically your 1st year of residency is really just kind of figuring out what you do like to do. So you don't need to know what you want to do when you start residency. And so during residency, you do a different, what we call rotation every month. And so the PGY1 rotations that I did, I listed on that side. So you start off with your orientation. You do have required rotations being internal medicine, transplant, oncology, and then 1 intensive care unit. And then we do have an outpatient requirement as well. So I did the anticoagulation clinic as mine. And in that, you just met with patients that were on warfarin, you saw what their INR was, and then made recommendations. So the 1st year is really kind of trying to be very broad, and so you can see all the different areas throughout the hospital. And during this year, you really learn more about what it means to work in a hospital, right? You learn what laboratories you need for different disease states. You learn how to interpret them. You learn how to read. We don't interpret imaging very well, but when we read the radiologist's interpretation, we know what it means. And so you learn what it means to work clinically. And then hopefully, if you do want to specialize, you learn where you want to do that. Because in the middle of your 1st year, then you would apply for the specialty 2nd year residency. You don't have to do it at the same hospital that you did your 1st year. A lot of people want to see different health systems, so they go somewhere else. I loved the hospital. I loved all of my co-residents, so I stayed at the University of Wisconsin for my 2nd year of residency. And then you can see the rotations that I took as a 2nd year emergency medicine resident, and you can see that they're much more focused on working in the emergency department. So I had 3 months in the emergency department. One was just regular. One was precepting, and so I had a student that essentially I was the preceptor for. And then one was working overnight, just to see if you like that. I do not like that. I cannot sleep during the day to save my life, but it was a good experience. But as you can see, I rotated through the neuro ICU, the pediatric ICU, the cardiac ICU. I didn't do the medical ICU because I had done that the first year, but had I gone to another hospital, I would have done that. Then you can see that the last rotation I did was toxicology, where I did spend a month working at the poison center with our toxicologists, because pharmacists in the United States are seen as toxicology experts as well. And so I did learn yesterday, in your hospitals, you do contact the poison center pretty frequently in the event that you think someone might be toxic on any sort of medication. We don't call the poison center unless it's a very large overdose and the patient is critically ill. Otherwise, we manage most of the tox cases. Any questions about rotations, things of that sort? No, okay. All right, so now I want to orient you to what the ED looks like that I work in. So we do have about 110 beds in our emergency department, and it's broken up into different kind of sections based on the acuity of the patient. And so we have the acute section, and that's where I work, and that's the most critically ill patients. We have urgent, that's kind of one step down. The clinical decision unit, which is the patients who are just waiting for the inpatient beds to open up. So essentially, we know that they're getting admitted to the hospital, but there's just no room yet. And we're lucky enough that these patients actually get taken over by the medicine service. So our emergency medicine doctors can be free to take care of patients that newly arrive to the emergency department. We have SuperTrack and Eval, which are kind of just urgent care clinics, not very sick patients. We do have a psychiatric section of the emergency department, a pediatric section, and then we have what's called an observation unit. It's on a different floor of the hospital, but it's considered part of the emergency department. And it's for patients who aren't sick enough to be admitted to the hospital, but we're not ready to send them home yet. So we do see about 300 to 400 new patients a day. The average waiting time, if you are being admitted to the hospital, is about 12 to 36 hours. I know there's a very wide range, but it depends on what you're being admitted for and if that sort of floor has open beds. I talked about our border service, and then we do transfer a lot of patients to affiliate hospitals if ours is more full than theirs are. So we do a lot of kind of patient transfers throughout different hospitals. As far as what kind of patients we can take, we are a level 1 trauma center, so we do get a fair amount of trauma patients. We're a national stroke center, so if anyone is having stroke-like symptoms in our vicinity, they bring it to our hospital. And then we are a STEMI center, so we can do PCIs at the hospital. So if they think you're having a heart attack, you also come to our center. So it's a very critically ill population, high volume, a very fun place to work, I'll say. So this is just a little picture of what the acute section of the ED looks like. As you can see on the outside border, those are where our patient rooms are. And then I've highlighted where the different specialties sit in the emergency department. So you can see that the emergency medicine doctors and nurses sit kind of right together, and then just to the left of that, and this is all an open space, so we can all chat with each other, are the physician's assistants. Right next to the physician's assistants is where the pharmacists sit, so we're right among the providers. We sit right next to the trauma physicians, so if a trauma does come in, they're right in the emergency department to take action, and then the respiratory therapist is right next to them. And then on the other side of the section, so still very close to us, are our neurologists, and so they sit in the emergency department as well. If we do have a stroke patient, they're right there to take care of them. And then we have another set of nurses to take care of patients on that side. So you can see it's a very open, collaborative environment. We are right among the providers, and so when a patient comes to the emergency department, either by themselves or they're brought in by the ambulance, we meet them in the patient room with the providers. We hear their story, we talk about what treatments we think would be best for them, and if it's an emergent treatment, say the patient is hypotensive or they need to be intubated, we are the ones that go and gather the medications and make them at bedside. So very involved in the patient care from the moment that they arrive in the emergency department. Questions about that? All right. So why is it important that we have emergency medicine services in the ED? As we know, this is a very fast-paced environment, high acuity, it's overcrowded, it's stressful. The doctors don't have time to look up all the medication information. We need to offload that so that they can really focus on tasks that only they can do. We often have incomplete patient information, so we have the time to look in their chart. We have the time to read about their history. And like we said, it's very fast-acting medication, so a lot of high-risk medication. So wouldn't you want a pharmacist in that environment to make sure you're using the medications as safely as possible? So this is the progression of pharmacy practice. So clinical pharmacy services in the United States have actually been in the emergency department since the 1970s, which is kind of shocking. And when I read that, I didn't think that that was the case. But you probably know about the Institute of Medicine report, "To Err is Human," that came out in 1999. So that said that building a safer health system in the ED was, there wasn't a safe health system because of the high rates of adverse drug events. And so the Joint Commission, which is our national accrediting body in the United States, said that all medications had to be reviewed by a pharmacist before they could be dispensed, to make sure they were safe for the patient. And this was especially true in the emergency department because these were the highest risk medications. And so this is really when emergency medicine clinical pharmacy expanded in the United States after the Joint Commission stated this. And so looking from 2007 to 2020, the training positions jumped from 3 to 70. So it's really ramping up in the training of emergency medicine pharmacists. So what did we start doing in the emergency department? We started doing medication histories and reconciliation because that seemed to be the most kind of obvious task that pharmacists would do. We would talk to the patients about their medications, make sure we had an accurate list in our system so that the providers knew what they should order when the patient was being admitted. So we were there to improve patient safety and patient care. However, we weren't yet specialized in emergency medicine. None of this really relied on our knowledge of emergency medications. And so they did this because pharmacists, they realized that pharmacists did document more errors in the medication history compared to providers. So they documented more interactions, more drug-related admissions, and previous drug failures. So much more medication information came out when a pharmacist provided this. And they saw that an inpatient pharmacist-driven medication history and reconciliation program led to about a 50% reduction in medication errors. So that's huge, right? And they saw that there was a lot of cost savings when pharmacists did the medication histories because we were reducing the risk of adverse events from medications that the patients weren't supposed to be taking. But the pharmacists realized that they weren't specifically the ones that needed to be doing the medication histories. They trained pharmacy technicians and pharmacy students to do the medication histories and realized that they did just a good of job. And so now we have what are called pharmacy extenders, and these are just either technicians or pharmacy students that can go do pharmacy tasks and take care of most of the work and then report back. So our pharmacy students and technicians that currently do the histories, they fill out all the medications, all of the information, and then they just send it to us to look at and co-sign. So that really relieved us to go kind of focus on what are more advanced tasks that we can do. And then my residency project, each year of residency, you need to do a research project. And so mine was looking at, okay, we know that pharmacists do better medication histories than providers, but what about ordering the medications? So should we take it a next step further? What if what if the technician does the history, we review it, and then we order the medications based on what we think is most appropriate and safe based on why the patient is presenting to the emergency department and what sort of their current clinical picture looks like. So the top chart is when the physician reordered the home medications, and we found that those medications, 42% of them had a medication-related problem with them. So either the patient should have been on a medication that they didn't order, they were ordered for a medication they were no longer taking, or it was a different dose, anything like that was a medication-related problem. And then in the bottom part, and we matched the population, so there are very similar populations in the cardiology and medicine units compared to our OBS unit. But when the pharmacist ordered the medications, this decreased to 1.2%. So that's a big decrease in medication-related problems. So now we know that patient safety increases both when we do the histories as well as when we actually order the medications. So this is moving us further and further to maybe having that provider status in the future where we actually order the medications ourselves. I will say in the US, we're not there yet, but hopefully moving in that direction with data like this. All right, so we've taken medication histories off of our plate. So now what did we start doing? Well, we know that the most common cause of medication errors is due to lack of information related to medication therapy. And so the provision of medication therapy or medication information from us to the doctors is the most important thing. And so we started advising. We started giving our opinions on the medications. They started asking us questions. And because of the Joint Commission, we also started reviewing the medications and verifying them and giving them our clinical opinion if we thought the medication was potentially inappropriate. And so this really moved us into being emergency medicine experts. So we were actually talking about emergency medicine and what we knew. And this brought us also to prospective medication review. So this decreased the errors because we were looking at the medication orders before they were being given. We also did culture follow-up. So this is kind of a difference that I learned yesterday of the United States and Italy potentially, is when a patient is seen in the emergency department and say we think that they potentially have a urinary tract infection, we will discharge the patient home before their culture comes back, and someone will follow up with them if it is either positive and we didn't give them any antibiotics, or it's positive, we gave them antibiotics, but the antibiotics did not cover whatever grew. And so pharmacists, because we knew about bacteria and we knew what antibiotics treated them, we became the people that would do those culture callbacks. However, this is now something that, again, we were like, we don't need to do all that because a lot of the antibiotics did cover what they grew. And so we were kind of not wasting time, but spending a lot of time looking at this. So now we've moved this to either medical students or our physician's assistants do them. And if the bug drug doesn't match, then they ask us. Then they ask us what we should do, and they're the ones that call the patient. So again, something that we were asked to do, but realized we probably weren't, we could spend our time in more appropriate ways as pharmacists. But this was the next kind of level of what we did in the emergency department. So after advising and order verification, then we started going to the bedside and being involved in resuscitation and procedural sedation. They wanted our help getting the medications, advising on what we should do, seeing if maybe the medication was too strong and the patient was too sedated, what would we do then? So the pharmacist was now seen as part of the medical team. So when we think about what resuscitations I'm involved in currently at the patient bedside, it's STEMI alert. So if we think a patient is having a heart attack, I will be at bedside getting the medications, including heparin, aspirin, atorvastatin, things like that, making sure that the patient is given these before they go to get their go to the cath lab. Code strokes. So strokes are a huge part of our day-to-day task. So the pharmacist actually goes with the neurologist to the CT scanner, and we wait for the radiologist to read the image, make sure that they don't have a bleed in their brain before we agree to make the thrombolytic. So we actually have to confirm with the radiologist the patient is safe to get the medication if they're having a stroke. So we're in the scanner with the neurologist, with the radiologist, and the medication at bedside. And if everything is okay, the patient is administered the medication within minutes. So very fast. So you don't have to wait for the medication to come up from the pharmacy, which is a much slower process. Code blue responses. So if a patient is in cardiac arrest, respiratory arrest, we have a code cart that has the most essential medications, and we are the one that gets the medications, hands them to the nurse, and we are definitely involved in the conversations of what we think might have happened to the patient based on their past medical history and what we think might help save the patient. And then rapid sequence intubations, we are involved both in the preparation phase, in the sedation and paralytic, what we would think is most appropriate based on their history, as well as it's very important the post-intubation phase and making sure the patient is appropriately sedated and has pain medications on board if they need that. So again, very present at the bedside in those medication discussions. And then what did we do next? So we're at the bedside now, and now we move into being having more opinions on cost. So do we think it's appropriate to make these high cost medications for a patient? Do we think that they need them? And so in order to create guidelines for the providers, we started making treatment protocols for different disease states. And I'll go through a few of the most common treatment protocols that we use in our emergency department that pharmacists have created that really helps guide providers in their ordering and decision making. And so they don't always have to ask us what we think that they should do. They all have access to these treatment protocols that again has made their job much faster. And the quality initiatives. So we have a lot of kind of quality initiatives going on in the emergency department. A lot of these become resident research projects that we can then publish and kind of pass that information along to different hospitals if we do think that we're doing a good job in something. So this kind of last phase really showed that we were the treatment experts, that we understood differentials and diagnoses. That's why we did the residency in the hospital. And now we started having not just clinical responsibilities, but more administrative responsibilities as well. So then this document was published now 2018. I guess the years of COVID flew by. It seems like this was just published, but this really outlined what the most important roles that we felt were for an emergency medicine pharmacist. So they still talked about ordering of home medications in the ED. Antimicrobial stewardship became a huge part of our job. Obviously, patients present to the emergency department very frequently with different infections. And I'll show you in the next few slides why we were in charge of antimicrobial stewardship. And then also just broadly in the management of critically ill patients. So really taking a part in that resuscitation. All right, so what did we do as part of our antimicrobial stewardship activities? So we knew how to target the most likely pathogens. So we knew where different bacteria grew in the body, and obviously as pharmacists, we knew what antibiotics were going to cover that. So we have a conversation with the provider, okay, based on your imaging, based on your diagnostic, where do you think the infection is? We know about our local microbial resistance. So every year we make an antimicrobiogram that kind of shows us what bacteria is resistant to what, so that we know what antibiotics work the best. We can review the risk factors and microbial data. So again, we have the time to look in the patient's history and see, say they did have a urinary tract infection, did they grow something recently? I will typically only look at the last year of culture data because your normal flora changes all of the time. And so say someone had MRSA 10 years ago, potentially they don't anymore. And so I usually will target in the last year or two. And then obtaining accurate allergy information, I think, is incredibly important so that we have the most antibiotics for our use as possible. And so pharmacists are really engaged in getting accurate allergy histories and potentially testing those allergies as well. So why can't emergency medicine physicians be good antimicrobial stewards? Because they are so busy. The emergency department volumes are so high these days, they don't have the time to be focused on, is this the right drug for whatever I think it is? They really go broad and then think about narrowing once the patient's admitted. For the pharmacist, we all think that it should be very focused and accurate from the start. And I'll show you in the next slide why that is. There's not great diagnostic tools in the emergency department determining is my patient infected, are they not infected? And so sometimes they don't know and we'll just put antibiotics on. So a lot of use of broad spectrum antibiotics without the pharmacist presence, without the antimicrobial stewardship. And obviously, putting antibiotics on quicker is very important. So if we do have a septic patient who comes into the emergency department who is hypotensive, is not doing well, I will go to our medication cabinet and get the antibiotic myself and mix it so that we can administer it as soon as possible. Our goal is always to administer all of the antibiotics that we would like to give within the first hour of patient presentation, because we know every hour that we delay antibiotics is an increased survival rate decreases by 7.6%. And so having the pharmacist in the emergency department really gets the necessary medications on board as quickly as possible. So, but does it matter that we just get it there quickly, or does it matter that we get the right drug there quickly? And so we looked at the survival rate if given the inappropriate therapy, even if it was quick. And the survival rate decreased from 50%, from 80% to 50% when the right drug was not started up front. So in studies, we see that about 15 to 20% of patients will get inappropriate therapy off the bat. So that's why we think it's so important to get the right drug at the right time right away. And you'll see in the second study, survival rate actually decreased from 50% to 10% if they weren't given the appropriate therapy. So definitely something to consider. And then, like I said, pharmacists are really engaged in penicillin allergies and antibiotic allergies altogether. And why do we care so much? We care because having antibiotic allergies on your profile that are not accurate and true are bad. You get prescribed different antibiotics that have more side effects that don't treat the infections as well. So you get more fluoroquinolones, you get more clindamycin, more vancomycin, so broader antibiotics that you don't need that can lead to more antimicrobial resistance. Clindamycin, we know that it causes more C. diff, so you're putting your patient at risk for more infections down the road by giving them these alternate antibiotics. We've also seen more surgical site infections when we're not using our penicillins, when we're not using our cephalosporins, because we know those are the agents that are best for our skin and soft tissue infections. And they are questionable. So about 95% of patients with reported allergies, when we did skin tests with antibiotics, did not actually have allergies. So they're not forever. Like I said yesterday, if you were here, 90% of true drug allergies go away in 10 years. So if someone is 70 and they had a reaction as a child, they likely don't have that allergy anymore. Not only because the allergy goes away as you age, but also our antibiotics are much more pure. It was typically the contaminants that caused the allergic reaction in the past. Also, medchem matters. So this is one of the charts that looks awful, but is great if you're a pharmacist. So we know what side chains that different antibiotics have and the likelihood of them cross-reacting. So say you had a reaction to ceftriaxone and they wanted to give cefazolin. It's likely okay because we know that cefazolin has a very different side chain compared to ceftriaxone. And some people would say, no, those are so similar to each other. But as pharmacists, we know the medchem behind the antibiotics, and so we have more knowledge about that and can be more helpful in medication selection. So if you do have the desire to really assess patient allergies, and I always urge physicians to do this as well, these are the questions that we typically ask. So what age did your allergy happen? Because again, the allergies go away. When did the reaction occur related to the antibiotic? So we know that true drug allergies happen within an hour of taking the medication 95% of the time. And so say they took 3 days of the antibiotic and then they developed some sort of rash. I would say it's definitely not due to the antibiotic. You can say it's probably not due to the antibiotic, but timing does matter. What did the reaction look like? Did you have a true full body reaction? Was it maybe just redness, maybe due to new detergent, something like that? Where did it occur? Like we said, was it whole body, localized? And did you ever re-challenge the antibiotic? So did you have it as a baby and maybe you've re-challenged it in the past and it was fine, or did it happen again? And have you tried similar antibiotics? So obviously the regular population who is not in medicine don't know the name of different antibiotics, but if you say, I had an allergy to amoxicillin, but yeah, I take Augmentin pretty frequently, then you know they don't have an amoxicillin allergy. And then I kind of touched on this yesterday, but this is a penicillin hypersensitivity pathway that infectious diseases pharmacists at my hospital have made. And essentially it just talks about if you had a reaction to a certain medication, are we willing to either just give a different medication because it's in a different class, or based on the type of reaction, so was it a rash that wasn't micropapular? Did you actually have anaphylaxis? If it wasn't a big drug rash, then maybe we'll test the antibiotic. So this is called our antibiotic test dose pathway. And so what we do is give 10% of the normal dose give it to the patient, wait an hour, and if they don't have any sort of reaction, then we'll give the full dose. So it's a very quick way to kind of get those antibiotic allergies off of the patient's profile. We also know the bioavailability of different antibiotics. I know in the emergency department, we commonly will give all antibiotics intravenously, but we don't have to. Yes, in your septic patient, you would probably want to, but say someone has a mild cellulitis and doesn't have any vital sign changes, they can take oral antibiotics. And so we know which antibiotics have the same bioavailability intravenously and orally. And so you could give it orally and it'll be just as effective. So just more information that pharmacists would be helpful in different scenarios. And then second dose antibiotics. In your emergency departments, when you order antibiotics, do you typically just do like one-time doses? Yeah. So that's also what we do in our emergency departments. But the problem with that is that the patients stay in the emergency department for such a long time. And by that time, our physicians are off seeing other patients, and we don't really think about that second dose of antibiotic. And so this study was done that looked at emergency department patients who were just ordered those one-time doses, and a third of the patients had to delay in their second dose of antibiotic. And we all know that infections are not treated with that first dose, and so getting the right timing of that second dose is incredibly important. And they did find that the antibiotics that are dosed more closely together, say every 6 hours, like our piperacillin and tazobactam is very common, 72% of those patients had a delay in their second dose versus the 8-hour antibiotics like cefepime had a delay of about 47%. And so this is really a space where pharmacists can be helpful because we track the patients who are on antibiotics. So if you protocolize the pharmacist to order those second doses, I can bet that there will be a much lower percentage of patients that don't get those second doses, which is very important, especially in your critically ill population. So I know that's a lot about antibiotics. So this will be kind of my last slide, but this is looking at patients in the outpatient setting. So when we look at patients with respiratory tract infections, those patients who received antibiotics, 50% of them were inappropriate. And antibiotic prescribing for all conditions, not just respiratory, 30% were inappropriate. And so this is very important when patients are leaving the emergency department back to home, that there's somebody reviewing the antibiotics. Now I know there's a lot of emergency department patients and it's not really feasible for pharmacists to review them all before they leave. And so a pharmacist in our emergency department retrospectively reviews them. So they look at patients from the day previously who were prescribed antibiotics, and if they deem that they were likely inappropriate, then they will contact the provider and potentially contact the patient. And this is a really, really cool study or project that a group of pharmacists did in an emergency department. And what they did was, instead of giving out antibiotics, because a lot of time antibiotics are given out to make the patient feel better, I think we all know that. So they, instead of antibiotics, they gave them little kind of care packages that had cough drops, tissues, hand sanitizers, and educational flyers telling them why they were not getting antibiotics for their illness. And this, by giving them the baggies, they decreased antibiotic prescribing by 84%. That is a lot of antibiotics that would have otherwise been inappropriately prescribed and taken that didn't need to be. And the healthcare team did think that this project was very rewarding because they knew that they weren't putting their patients at increased risk of potential adverse effects from the antibiotics, potential antimicrobial resistance. So these are just like little things that you can do that can make a big difference in your patient care and prescribing practices. All right, so kind of some key takeaways on antimicrobial stewardship. Penicillin allergies do matter, and they can really optimize patient care in the ED. ED pharmacists, in my opinion, have a significant impact on antibiotic use and limiting durations of therapy and on discharge prescriptions. Emergency department engagement is essential, really, for stewardship, because we're the place that we can catch patients both being admitted and stop antibiotic prescribing before they're admitted, or ensure their antibiotics are being given appropriately, and before they go into the community. So we're kind of that base where we can catch a lot of the inappropriate antibiotic prescribing. And little things go a long way, right? So giving those little care packages decrease prescribing by 84%. So even though you think you might not be making a big difference with these initiatives, you really are. And we didn't even touch on a lot of these things that we're involved with in the ED, including post-exposure prophylaxis, infection control efforts, antibiotic indications on the orders. So in our electronic health record, when a physician orders an antibiotic, there's different buttons of different infection sites. So example, intra-abdominal, pneumonia, UTI, they actually have to click whatever they're treating so that we know what they think that they're treating, so we can ensure the antibiotic is appropriate. There is another button that used to be very popular, and then we hunt them down and make them tell us what they think they're treating, but just doing that, adding the indication to the ordering button, has been very effective in our antimicrobial stewardship as well. All right, so now we'll move on to the treatment protocols. So having a pharmacist involved in creating different treatment protocols, like I said, has made us thought of us as treatment experts, right? So that we have a say in what we think the most appropriate medications are in treating different disease states. The most commonly used ones and ones that were most recently created were our sickle cell crisis management protocol. We're seeing a lot more sickle cell patients in our emergency department because we recently added a pain management outpatient clinic to our hospital. And so if their pain isn't being managed in the clinic, then they will come to the emergency department for further medication therapy. We have different treatment pathways for pain, including ketamine, lidocaine, and magnesium. We have DVT and PE treatment pathways for both inpatient and outpatient use. We have a treatment recommendation pathway for agitation in our geriatric patients, pediatric patients, and just your typical adult. We have alcohol withdrawal pathways for both complicated withdrawal and uncomplicated withdrawal that include both our benzodiazepines as well as phenobarbital. And then our anticoagulation reversal protocol. So this really came about when Indexinate alpha came on the market. As we all know, it's very expensive, and so we needed to make strict criteria of when we think that it would be appropriate for use and when it would not be appropriate for use. Obviously, we are not the final say in any medication ordering because we're not prescribers. And so, for example, with our anticoagulation reversal protocol, if it's not a criteria that we've deemed appropriate, the emergency medicine provider can still contact the hematologist. And if the hematologist says that they think it's appropriate, we can still give it. So even though we have these protocols and criteria, it's not like a hard no. So this, I know it's very small. I will zoom into the pharmacy parts, but this is an example of our sickle cell pathway. And essentially the first part is just kind of the assessment. So what laboratories should be added, what imaging should be done, and if you're concerned about, say, acute chest syndrome, things of that sort. And so that's really where the physician created that part of the protocol. And then we created the treatment protocol. So it's very important to do multimodal therapy with our sickle cell patients so that we have several medications that work on different pain systems. So in the first box, you can see that we recommend Tylenol, ketorolac, and some sort of IV opioid for the patient right up front. We do give recommendations for fentanyl, morphine, and hydromorphone that are pretty equivalent to each other and that we found are effective for most of our sickle cell patients. And then in the bottom box, we have kind of, if you want to switch from IV to oral, once the patient's pain is under control, how the provider could do that. So again, we're just giving initial recommendations so that the providers know sort of what kind of doses are appropriate, and then later on how they would convert the patient to oral medication, because then we take the time that they would spend looking that up out of the way so that they can focus on diagnosing other things in other patients. And then we're also involved in publications. So because I have an interest in sickle cell disease, I recently published a paper in the high-risk, low-prevalence diseases section of the American Journal of Emergency Medicine. This does specifically look at acute chest syndrome, but it goes through the whole disease process altogether. And so what I put in here that was medication specific is what antibiotics you should use for acute chest syndrome, because it is a kind of a unique disease state because you have to treat more of your atypical bacteria. And then I also put what an example pain control regimen would look like. So what we like to do and what we're recommended to do by our manager is to take our protocols and publish them nationally so that other hospitals can take our protocols if they would like to, because then it just makes their treatment easier, but also so that other people can see what our institution is doing. So you'll kind of see this common theme that we have an institutional protocol, and then we also try and publish it. This is our alcohol withdrawal pathway in the ED. This is specifically our severe alcohol withdrawal. If I didn't show the mild to moderate withdrawal, but that one has our benzodiazepines. You guys probably know if you use a benzodiazepine, you either use lorazepam or diazepam most commonly. Our hospital uses more lorazepam. So lorazepam is in our protocol. And then it also has intramuscular phenobarbital. Intramuscular phenobarbital is good if the patient has like a history of alcohol withdrawal, but because it takes longer to have effect, we typically don't use it in our severe alcohol withdrawal where the patient is actively pretty ill. So this protocol breaks it up into phenobarbital IV or more lorazepam. So if we look at the phenobarbital IV, our providers were like, well, what kind of dose do we give them? And we say, well, it matters how much benzodiazepine you've given them before, because if we give a lot of lorazepam and then a lot of phenobarbital, we're at risk of causing sedation, unwanted sedation. And so we've advised them that if they've given quite a bit of lorazepam, that they should just give small intravenous doses every 30 minutes based on how the patient's doing. Versus if they didn't give them a lot of benzodiazepine, then we can give that kind of big load of phenobarbital up front, which is our 10 milligrams per kilogram, and then again reassess every 30 minutes. So we recommend the dose. But in addition to recommending the dose, we also recommend how to give the medication. So we know that large doses of phenobarbital, if given quickly, can cause pretty significant hypotension. And so if you're giving your little boluses like 130 milligrams, 260 milligrams, you can just push it, just like a bolus. But if you're giving the 10 milligram per kilogram dose, we recommend infusing it over 30 minutes. And so that's also something you can put in the treatment protocol so that it's not missed and you increase patient safety. And it's something that the nurses see as well. So these treatment protocols have a lot of information in them that's helpful for both physicians and nurses. And then this is our severe agitation pathway. It's broken up into less than 18 years old, so the pediatric, that's yellow, yeah. The pediatric is in the yellow, the adult is in the green, and then the geriatric patient is in the red. And you can see that the geriatric section is broken up into potential causes of agitation, because that will determine how we treat it. So there's psychiatric, dementia, if they have Parkinson's, and then if they are delirious. And so Parkinson's, as we were talking about, matters because you don't want to use your first generation antipsychotics because they will make their movement disorders worse. So this breaks it up into patient population as well. Just another example of how we can give recommendations that vary quickly to providers. They can easily look up the protocol versus potentially spend an hour digging through up-to-date, digging through different sort of online recommendations. It's just right here at their fingertips. And then again, because we helped develop this protocol, we wanted to publish it. So I worked alongside Mara Kennedy, who's one of our emergency medicine providers, who specializes in geriatric medicine. And we just made it, along with discussing agitation in the geriatric population, we made this kind of helpful flow sheet that looks at what you should ask yourself when an agitated patient comes to the emergency department and what medications are most appropriate based on kind of your thoughts and opinions. So again, another example of We have our institutional protocol, but then we did publish it so that everyone can see it as well. All right, so that was an example of our medication stewardship being our antimicrobial stewardship, and then looking at our different medication stewardship protocols as well as treatment pathways. So kind of the last progression of emergency medicine is when we started teaching. So we started teaching pharmacy students, we started teaching pharmacy residents, we teach physician residents, and we do clinical research. So we're very involved in research and publishing. Like I said, every year of residency, you have 2 research projects at our hospital. So a lot of research is coming out of the pharmacy department. And this is a little Twitter thing that I thought was funny because it's antibiotic related, but it says, you have to teach early and often because education has the half-life of a beta-lactam, which is quite short. So a lot of teaching. And then we also do discharge counseling, so we teach our patients as well. These are typically patients who are leaving the emergency department, not getting admitted, but we do have what we call meds to go, and so they don't have to go to the pharmacy. We will give them the medication before they go home. So if a patient has a DVT or a PE and we think that they're stable enough to go home, we have starter packs of both rivaroxaban and apixaban that we bring to the patient bedside, open them up, and kind of go through how the patient should take them. Because we know in that first month of treatment, the dosages change. So for rivaroxaban, they take the 10 milligrams twice a day for 21 days. Then all of a sudden at the 22nd day, they go down to 20 milligrams once daily. And that can be very confusing. The manufacturer does a good job of trying to change the label and make it as clear as possible, but it still can lead to problems. And this is very important with a medication like a blood thinner, because if they take too much, they're at high risk of bleeding, but they also have a clot. So if they don't take enough, they're at risk of the clot getting worse. So we thought that this was a very important medication that we talk about with the patient before they go home. We also have EpiPens for patients who have allergic reactions. We instruct them how to use their EpiPen. We have inhalers. This is most common in our pediatric patients since using inhalers can be kind of tricky. So we talk about that. And then we also have a naloxone nasal spray that we give out to patients who came into the emergency department potentially for an opioid overdose. And then Lovenox, say they also have a clot and are being sent home on Lovenox, maybe because they have a history of cancer. So we show them how to, along with the nurses, because obviously we're not administration experts, but we talk about how to administer the Lovenox injections correctly. So just some examples of how we talk to the patients as well about their medications at the patient bedside. One initiative that we recently started in our emergency department over the last few years that is near and dear to my heart, I think is very important. At MGH, I am a chair of our substance use committee. And so we started this buprenorphine to go program. Do you guys do a lot of Suboxone here in Italy? Or are you like more methadone for your opioid recovery patients? You know. So methadone is kind of tricky because in order to get your methadone dose, the patient has to go to the methadone clinic every single morning to get it, which is obviously very disruptive for their daily life. And when you're recovering, you obviously want to begin to recreate a life, potentially get a job, and so methadone can be hard for those patients. So we're moving more towards Suboxone, which is the combination of buprenorphine and naloxone into one little strip. And so we now have a law in the United States that we can dispense a 3-day supply of Suboxone to patients who are leaving the emergency department in order to give them time to connect with an outpatient clinic. And so they'll have a 3-day supply. So how we've done this, so we have 6 films because the maximum amount of Suboxone we want patients to take per day is 2 films. So this will get them through the 3 days. So we have an empty bottle of these films in our medication cabinet in the emergency department. When the provider comes and chats with us and says, I think a patient is appropriate for Suboxone to go, they're willing to connect with an outpatient addictions clinic, will you go talk to them and give them the medication? Then we fill in the patient information onto the label because it has to be legally okay to be sent home with the patient, so their information has to be on the bottle. And then we provide them and discuss with them this information sheet. So how do they start taking Suboxone? When should they start taking Suboxone? Because it's very important, if the patient is not in some sort of withdrawal and they take Suboxone, it will induce withdrawal and the patients will likely never take Suboxone again. And so we have to tell them, you have to be in mild to moderate withdrawal before starting it. And then we tell them how many doses to take based on their symptoms, how to start the dose on day 2, and things of that sort. So we talk them through it and answer any sort of questions that they might have. And then we also give them the naloxone nasal spray to go. So this is a great program. And so of course, like everything else, we published our results on it. So Jimmy was our resident last year, and we looked at, so we give the patient this 3-day supply. How many of these patients actually do continue taking Suboxone and continue in their recovery? And so we looked at 242 patient records and included 155 patients in our results who had been given our 3-day supply. So 70% of the patients continued filling buprenorphine at 3 months. So that's a pretty good amount of patients that continued to take the medication. And then 64% of the patients continued filling at 6 months. So still a pretty good amount, and this is comparable to other studies as well. And then we also looked at how many patients did we give Suboxone to that ended up coming back in with another overdose event. And we saw that only about 11% of patients had been readmitted to the emergency department for an overdose. So I'd say this project was pretty successful. But we know that not all patients are willing or ready to enter recovery. And so we also think that harm reduction is incredibly important as well. So if the patient isn't ready to get our Suboxone kits and enter recovery, we also have safe injection kits that we provide the patients. So these consist of clean needles, filters, sterile water, alcohol swabs, things of that sort. So we also provide these. So we're really trying to connect our emergency medicine services with the community. And how can we not only help the patients in the emergency department, but how can we help them once they enter the community as well? And you'll see in one of my later slides, I think this is a really important kind of future step for the emergency department to take, and and there's a big role for pharmacists to play in that. And we are also very involved in cost effectiveness, as we talked about. So there's a lot of high cost medications that we can use in the emergency department that aren't always appropriate. So we talked about Indexa, which is Indexinate alpha, the reversal agent for our anti-TNA inhibitors. We've got Sugamidex. So say our patient is given a paralytic, and for some reason, it's always the neurologist wants to reverse it, but Sugamidex is very important. So we're definitely involved in those conversations. There's clofidipine. So clofidipine is also pretty expensive. Our providers love it because it's very easy to titrate. It's a very precise medication, but oftentimes your patient doesn't need that precise of titration, and nicardipine, which is much cheaper, can be used instead. Bivalirudin, so that's an anticoagulant that is often used in our patients with heparin-induced thrombocytopenia. We talk about those conversations, involve our hematologists. So a lot of medications that we have conversations about and save a lot of money not using them if not appropriate. And then, like I said, we're very involved in education. So our Harvard physician residents have a weekly conference, and for 1 hour every week, one of myself and my colleagues goes and teaches on a clinical topic so that they learn more of kind of the medication aspect of it, which we've gotten great feedback on. Our nurse practitioners also have a conference that we go and teach at. Our nurses have weekly grand rounds. Pharmacists have weekly grand rounds. We also have different national organizations that we go and teach at. So ACEP is the American College of Emergency Physicians. Within the last 4 years, they have started inviting pharmacists to talk. It used to just be physicians teaching, but now they're having more pharmacists come and talk. ASHP is the American Society of Health System Pharmacists. So that's the big organization for pharmacists who work in hospitals. And they have different subcommittees. So last year I was the chair of the Emergency Medicine Section Advisory Group. for that committee. So a lot of ways to get involved. And then we also have local conferences. Each state has its own pharmacy society that has yearly conferences as well. So a lot of opportunity for us to go and share our knowledge, which I love. I love teaching. So you're not only working in the hospital, but you're also sharing your knowledge elsewhere as well, which is a lot of fun. And we have different internal committees. So you are expected to have some administrative responsibilities to improve the care of the hospital at large. So these are the committees that I sit on and either chair or just a member. So we have our Emergency Department Operations Committee, and this just talks about different protocols, different initiatives, the workflow of the emergency department. So very broad topics. It's not always medicine focused. But when it is, it's typically us presenting the information. I do chair the Pain and Palliative Care Committee, and this looks at different pain regimens, how we are treating our palliative care patients. Again, I'm part of the Substance Use Steering Committee. I'm part of the Committee on Quality of Stroke Treatment. So are we using the right medications? Are we using them in the right patient population? After we give the alteplase, what happens to our patients? And then we also have a geriatrics optimization task force that I'm also a part of. Currently in that committee, we're trying to create order sets for our providers for different disease states in our geriatric population, since a lot of the medications and doses that we use are different. So different things to help our providers as well. And I do want to point out that all of the committees that I listed on the slide are not just pharmacists. All of the committees have physicians, nurses, pharmacists, case managers, so they're all very multidisciplinary. And again, we're considered a big medical team. So what does my day look like? So every month I precept either a resident or a student or both. We have a lot of layered learning going on at the hospital. So there's oftentimes a pharmacist, a resident, a student. Sometimes there's a pharmacist, a second-year resident, a first-year resident, a student. So a lot of learners on rotation. So my shifts are typically 7 a.m. to 3 p.m. And during that time, because I sit in the acute section, I'm always seeing the patients when they arrive. Because I sit amongst the nurses and providers and they just turn around and say, "Hey Jenny, I have a question." We're constantly getting medication questions that we answer. Because there is the requirement for us to look at all of the medications and verify them within the computer before they are dispensed. I look at all of the medications that are ordered for all of the emergency department patients, which can be a lot. As I put on the slide, I look at about 250 to 350 medication orders a day, so quite a lot. Emergency medication preparation, again, if there is a critically ill patient, I am preparing the medication at the patient bedside to get it to them as soon as possible, and then participating in all the resuscitations and sedations as we talked about. So we do have patient care rounds for an hour every morning with the physicians, nurses, and us. And then from 11 to 2 is typically when we have our committee meetings. I do any of the sort of teaching, if there's conferences, things of that sort. And then from 2 to 3, the PM pharmacist will be coming in, and I chat with them about the patients. I tell them why the patient presented, what we've done so far, what medications we've given, and where I think the patient's condition is going in the future. So we do a lot of kind of a warm handoff from pharmacist to pharmacist. So what are the benefits of having a pharmacist in the emergency department? So we talked about a lot of different ways that we reduce adverse events and adverse drug events in the emergency department. And it's mainly because we are there at the initial conversation of what medications are going to be given. So we not only review them after they're being ordered, but we save a lot of time when we're there in the initial conversation. We reduce time to medication administration, again, because we can actually make the medication and give it to the nurse to administer. We increase adherence to evidence-based national guidelines, and how we do that is by making our treatment protocols. So we make sure that what our providers are ordering and what sort of treatment we're giving are based on the national guidelines. We improve utilization and cost-effective drug therapies. So if someone orders a very cost-effective, very costly medication, are we ensuring that it is essential? We do elevate physician and pharmacist training because Our physicians also rotate with us. So one of our pharmacists is a toxicologist, and so they do part of their toxicology rotation with the pharmacist because they really get that background information on the medications, which they have found very helpful. And we have happy ED physicians and nurses because we take the time that they would look up medication information, that they would have to find things on their own, and we give them that time back so that they can do tasks that are more appropriate for their training, so that we are all working at the top of our license and doing the things that we're trained for. So Giovanni asked me to talk about how you optimize the pharmacist role, and I think it's really simple. I think it's putting the pharmacist within the care team, because that's what we are. We are the medication experts. Physicians are the diagnostic experts, and so put us at the bedside, put us within those conversations about the medications. That's really how you optimize pharmacist training and the pharmacist role within the medical team. So where do I see the future of emergency medicine and clinical pharmacy in the future? So I have a caveat here that what the pharmacist is able to do and what the pharmacist is hired for at each hospital does depend on their patient population, because not all hospitals are trauma centers, not all hospitals are stroke centers. So some hospitals don't need the pharmacist at bedside as much. And so sometimes the pharmacist is close to the emergency department, but maybe in a workroom. They're not sort of at the patient bedside. In some hospitals, that's okay. Some hospitals don't have 24/7 coverage. They only have coverage maybe from 10 a.m. to 6 p.m. because that's when they have their highest volume. We are lucky enough to have a pharmacist physically in the emergency department at all times of the day. And I think that's very important, because then the providers always know you're there. They know how to integrate you into their practice. It's different when you have a pharmacist there some part of the day and you rely on them, and then you don't have them the other part of the day. But it does depend on the funding of the hospital. Do you have money to hire pharmacists to be there? But I will say that the services that the pharmacists provide, the drug events that we avoid, things of that sort, the cost effectiveness that we provide, you do get that money back from hiring the pharmacist, and all studies have shown that. So future of pharmacy, I think what should happen is all emergency departments should have pharmacists there all of the time, at the patient bedside in those conversations. I think that we should have greater involvement in physician training. I think there should be pharmacists more involved in the medical schools. I think that there's not enough time talking about the medications. The treatment is so important to get it right at the right time, as we talked about. So pharmacists should be present in the medical schools as well. We should, and we're starting to, be present at the national conferences, so teaching nationally. Obviously, as a physician, you go to these conferences to get continuing education. Well, a lot of that education should also be on medications, because our medications are constantly changing. And so you should continuously be updated on that as well. In the US, we don't have this, but I was reading in some parts of Asia and the UK, they have what are called ED pharmacist practitioners. And they have found that emergency medicine pharmacists are able to actually diagnose and treat patients, likely, obviously, with more of the less complex patient conditions, but they are actually having pharmacists be the practitioners. And I think that we definitely need more kind of research looking at this and ensuring that it is safe. But I do think that this is a way, potentially a way of the future. More prescribing protocols. So one example I gave today was protocolize the pharmacist to order the second dose of antibiotics. If we think that the first dose was appropriate, likely the second dose is appropriate as well, and we just want to make sure that the patient gets that on time. There's a lot of protocols in the US. If a patient has decreased renal function, can the pharmacist change the dose of the medication to make sure it's appropriate for their renal function? That's something that we know how to do. So different things of that sort, changing the medications to make sure they're appropriate, should be protocolized to the pharmacist, because typically the pharmacist sees that, they have to go to the provider. The provider is never going to say no, because you provide the correct information, and then you have to go back and do it. So it just saves a lot of time. And then public health initiatives. I talked about a few in our safe injection kits, in our Suboxone to go, but I think there should be more. MTM stands for medication therapy management. Some of our retail pharmacies are starting to do that, but essentially they make appointments with patients out in the community to bring in their medication list, to review their medication list, make sure all of the medications are still appropriate. And I think we just need to better blend the inpatient and outpatient side, because it's still pretty siloed in that when a patient leaves the ED, the outpatient provider doesn't really know what happened. So we want to really just make sure that transitions of care is as safe as possible. And I will say that there is quite a bit of support from physicians in the United States for the emergency medicine pharmacist. So I was talking about the American College of Emergency Physicians, but also the American College of Medical Toxicology have these position statements that I have put on the slide that really endorses the value of the emergency medicine pharmacist, and they recognize our impact on the evaluation and management of the emergency medicine and toxicology patient. So they not only recognize that we understand the medications, but they recognize that because of our clinical training, we are able to help evaluate. We are able to be present in those management discussions. So it's really important that we have the support of our providers as well. And that is all that I have today. I would love to hear your thoughts, your opinions, any questions. Do you guys think you have a better understanding of my day? I know sometimes it can kind of seem like a foreign concept and kind of hard to picture, but there's a lot going on every day, definitely. Any questions about our training?
You choose in which ward you go, or they send you. I don't know how to do that.
Yeah, so there's both. So the first year residency, like I said, they really try and educate you on a lot of different disease states. And so in each residency is different based on what they require. So we have our required rotations, which is your general medicine, oncology, transplant, pediatrics, and then one intensive care unit. And then you have like 3 electives that you can just pick based on what you're interested in. So I picked obviously the emergency medicine rotation and then a few other ICUs just because I knew I was interested in critical care. And then for my second year residency, you have to do 3 months in the emergency department. You have to do 2 ICUs, and then the rest are elective. Oh, yeah, and you have to do toxicology. So there's both ones that you can pick, but there's also required ones. Oh, I see. It's like paper exams. We do have what are called OSCEs, in that they hire fake patients. They're like actors. And so they pretend like they're patients with some sort of like medical issue, and it's usually based on their medication, obviously. And so we go introduce ourselves, and we try and get all the information that we need in order to determine what the problem is. And then we have to talk about what we think they should do, and we educate them on their medications, and those are like recorded. And then our professors watch them, and we're graded on those as well. And I didn't talk about this. It's in my next lecture on just clinical pharmacy in general. But we do have what are called introductory pharmacy practice experiences during our first and third pharmacy year. And those are all 1 month each. So we have like 1 each year. And so we have 1 in the retail setting to see what that's like. We have 1 in the inpatient setting, typically just in our central pharmacy. And then we have 1 elective. Some electives you could work in like the perioperative pharmacy, you could do clinical trials, you could go to industry. So those are just kind of early on experiences just to show us what the inpatient side looks like, outpatient side, and then whatever you're interested in. And then our 4th year of pharmacy school, we are done with all of our didactics, and it's called our advanced pharmacy practice experience. And it's, again, 1 month long, so you have like 9 of them, and you rotate through different areas of the hospital. So it's kind of like a mini residency, our 4th year of pharmacy school.
Okay, there are some questions from home, online people. For example, from Professor Realdon.
Yes, good afternoon to everybody.
Thank you. I would like to introduce Professor Realdon. He's the coordinator of 4 School of Specialties in Hospital Pharmacy of Italy. He's a professor of Padua. Please, Nicola.
Yes, thank you, Giovanni, for your hospitality. First of all, my congratulations for your clear presentation. That is very interesting. And I can say that it's a real pleasure to have you as a guest in this conference. And above all, I can tell that was very interesting to hear your experience in pharmacy practice in emergency medicine. I think that for our hospital pharmacy students, this is a completely new professional area, and I think unknown maybe. It is certainly an excellent experience for me in which clinical pharmaceutical practice enters into concrete fulfillments. I would like to have some information about your presentation, especially about the logistic aspects of the organization. Logistic aspects related to how many pharmacies are needed to support a service like that you have explained in your presentation. Probably something is wrong in the transmission, maybe. Giovanni, do you listen to me? Giovanni? Mi sentite?
Sì,
Però
professore.
da casa noi la sentiamo. Deve essere un problema della connessione al collegio.
Sì, con chi parlo? Chi c'è?
Noi riusciamo a sentirla perfettamente.
Avete sentito la domanda che
No,
Voi
l'abbiamo sentita, ma
Noi sentiamo. Noi sentiamo.
dal collegio che non la sentono. Dal collegio che non la sentono.
Mentre voi mi sentite?
Sì, però si è sentita male la sua domanda.
Allora provate a avvisare il collegio che io esco e rientro.
Ok, proviamo a scrivere in chat.
Grazie.
Okay.
Hello, good evening. Somebody can tell me?
Ancora bloccato.
Noi ci siamo.
Non riceviamo più niente neanche noi dall'app, quindi penso sia un problema là.
Ah, ecco, perché appunto io adesso vedo anche lo schermo nero, cioè una parte del mio schermo è nero.
È una parte centrale?
Sì.
Anch'io, anch'io.
No, io vedo ancora le slide invece.
Anch'io vedo le
Sì,
slide.
sulle slide c'è una sorta di quadrato nero, almeno a me spunta questo, non so.
Niente da fare, eh? Però io ho avuto anche un grosso problema a entrare oggi. Era un quarto d'ora che cercavo di entrare, sono riuscito a entrare dopo un quarto d'ora.
Ma quello è perché loro erano in ritardo proprio. secondo
Ah,
me.
ecco.
Anche ieri comunque.
Sì, infatti ieri vi ho risposto
Anche-
perché la segna Sottara la dottoressa Sottara mi aveva segnalato che non riusciva a entrare, ma io vi vedevo.
Ma anche più di un quarto d'ora abbiamo atteso ieri.
E abbiamo aspettato un po' all'inizio.
Sì, è un qualcosa di loro perché è possibile che ci sentiamo tra di noi che stiamo assistendo.
Sì, presumo
Sì,
anche
sicuramente.
Beh, che chiacchieriamo tra di noi, non c'è problema.
Provo a iscrivere se... esatto.
Prof, ci illustri qualcosa?
Cosa volete che vi illustri?
Qualcosa inerente all'argomento di oggi.
Molto interessante, ma lontano anni luce dai nostri.
Io personalmente, se posso dire la mia, temo che ci sia proprio un gap da un punto di vista organizzativo, cioè per quella che è la predisposizione dell'insegnamento e dello studio nei due ambiti, quello medico e quello farmaceutico, temo che non sia ancora adeguato per un servizio del genere, cioè per una collaborazione di questo tipo.
Assolutamente sì, sono ruoli troppo ancora distinti, il ruolo del medico e del farmacista.
Penso che comunque piacerebbe un po' a tutti eventualmente collaborare da questo punto di vista, però il mio pensiero è che comunque non ci siano appunto delle basi per fare questo, cioè la figura del farmacista anche da un punto di vista clinico non è tale da permettere una collaborazione di questo tipo comunque che ci è stata illustrata oggi.
Okay, I am Professor Eldon, and I was talking when we had the blackout, and I was talking about the pleasure to have you as a guest in this conference, and I think the items that you proposed in your discussion are very, very interesting, especially for our students. And the specialist in hospital pharmacy. I think that for our hospital pharmacy students, this point of view is completely new, is a new professional area, and I think that probably is quite unknown. It is certainly that you presented an excellent experience in which I think clinical pharmaceutical practice, as I told before, enters into the concrete fulfillment. And the question that I had for you is to have some more information about the logistic aspects of the organization. Logistic aspects especially related to how many pharmacists are needed to support this service. Also, well, this is the first question for the moment. Thank you.
Just to clarify, do you specifically mean how many emergency medicine pharmacists or how many pharmacists in the hospital?
Sorry, I don't earn more anymore. Sorry. What?
Dove
Niente.
Quale sarà il microfono adesso?
Prof ricevuti? Prof?
microfono USB.
Now?
Prof, si sente molto basso, dovrebbe attivare il microfono che inquadra la dottoressa.
E quello non funziona purtroppo perché è da un'altra parte. Abbiamo provato prima ma è andata via la voce. Così riuscite a sentire almeno qualche cosa?
Just a little.
Talking to this.
Can you...
Can you hear me?
Meglio, sì, va bene.
Ok. Adesso va bene? La sentite adesso?
Hello?
Can you speak?
Can you hear me?
Yes, we can.
Okay, perfect. I just wanted to clarify, as far as the number of pharmacists to support this, were you asking about specifically emergency medicine pharmacists or pharmacists throughout the hospital? I'll answer for emergency medicine. So we have a total of 6 emergency medicine pharmacists. 2 of them are only on overnight, and the rest of us do either the morning shift or the evening shift.
Professor Riordan wrote on the chat that he can't hear anything. I think it's a problem of his microphone, but he can't hear you and anyone who's speaking.
E qua è il microfono.
Penso che sia il suo microfono del prof che non funzioni.
La dottoressa si sente, è il prof Rialdon che non c'è più.
Esatto.
Sta scrivendo in chat il prof Rialdon, perché ha detto che non sente più nulla. Mi sa che è caduto tutto di nuovo.
Io non sento nulla. Io non sento nulla, non so se voi mi sentite, ma io non sento nulla.
Adesso non stanno parlando proprio ricevuti, però noi sentiamo lei.
Come prima.
Professore, scusi, ma lei riesce a sentire noi?
Molto lontani. Alcuni sento vicini e alcuni lontani. Voi riuscite a sentire me?
Sì.
Noi riusciamo a sentirla.
Sì, sì, adesso la vediamo anche.
Io sento molto lontano, non so se voi sentite me.
Sì, anche noi la sentiamo un po' lontano.
Penso che sia un problema di collegamento con la sala. Va bene, non importa. Voi riuscite a parlare con la sala? Qualcuno di voi riesce a parlare?
No, ma è caduto di nuovo come prima la linea, penso.
Ecco, vedo strisce nere sullo schermo. Non so se mi sente, ma io vedo strisce
Sì,
nere.
quello lo vediamo anche noi, però non c'è ancora, non si sente niente dalla sala, ecco.
Chi ha parlato adesso lo sento molto distante.
Sono io, Patrizia Brichese. Dicevo che noi vediamo anche noi quelle linee sullo schermo, ma non si sente niente dalla sala, quindi non hanno connessione evidentemente.
Anche da voi io sento molto.
Okay, to answer the question about how many pharmacists we have to support all of this, we have a total of 6 full-time pharmacists in the emergency department. 2 of them only work overnights, so they do 7 on, 7 off overnight. And then the 4 of us do a split between our AM and evening shift. And then our second year resident, so our emergency medicine pharmacy resident, also does shifts independently. So he can fill a pharmacist's shift as well.
Well, I don't know if you listen to me, but thank you. I can have very in distance. If you not, you hear me.
And then I will say that we also can work in different areas of the hospital. So I have a clinical interest in the neurologic critical care population, and so I also work in our neuro ICU, and one of our neuro ICUs comes down and works in the emergency department. So you do also have the option to cross-train to different areas if you are interested, just because during our residency, we do get so much critical care training that we are able to work in the intensive care unit as well.
Okay, other questions from online people? Qui voi avete domande da fare? Prego, hai domande? Adesso are you hearing us, all you online, are you able to understand what we are... Non risponde più nessuno?
Yes.
Noi la sentiamo.
Okay, so do you have any other questions? No, probably not. Voi non avete nessun dubbio, nessun problema? We can stop. Ok, allora se non... so, if you don't have any other question, I would like to thank you very much for your attention, your participation, and also especially Professor Curl for this lecture. Very interesting. I think that we have a lot of questions. Personally, I have a lot of questions, but we will discuss in the next seminar probably, or via chat or via email to have a continuous collaboration with Professor Cole from Massachusetts General Hospital. I thank you very much. We can stop this connection.
Thank you.
Okay, because the problem is very important. We have, for example, about the connection with the analysis. Okay, thank you very much for your presence attending this new lecture of Professor Jenny Cole from Harvard University and Massachusetts General Hospital. As I told before, she is the coordinator of didactical activities for residents at Massachusetts General Hospital, for residents from many universities in Boston and also out of Boston, yes, in USA, and she is a pharmacist, especially she is working in emergency department of Massachusetts General Hospital. Now, this evening, the topic is very, very interesting. Is introduction to clinical pharmacy practice. Very important for us because in Italy this is a new topic, this is new idea, this is new way to work in team in hospitals and in several departments. I thank you very much, Professor Cole, for his lecture. Thank you. Please.
Thank you, and thank you all for joining. Please let me know if you ever would like me to slow down talking. Sometimes I start talking pretty quickly. And most of you are tuning in virtually, so I would love your participation throughout this. We will have some clinical cases at the end where I really just show you where a clinical pharmacist would be helpful and intervene. But this is pretty informal, so please feel free to interrupt me throughout the presentation and ask questions, because I know sometimes we forget by the end. But like Giovanni said, I do work in the Massachusetts General Hospital. I do work in the emergency department as I specialized in emergency medicine. But today I'll be talking more broadly about just the practice of clinical pharmacy throughout the hospital. All right, so I just wanted to start off by kind of understanding what pharmacists do in Italy. I had the pleasure of sitting down for dinner with some of our pharmacy students last night, and I learned that the majority of pharmacists do work in what we call retail pharmacies in the community setting. Some pharmacists do work in the hospital, but it's more of what we call centralized, where you work in the pharmacy of the hospital and not really on the patient care floors within the medical teams. So I'm just wondering, are there any settings where pharmacists work that I'm missing?
You ask what pharmacists in Italy?
Mm-hmm.
When you graduate, you have two choices. You can go and do admission for residency, but not paying, then to study around 4 years, and then they can work in the hospital, so it's a pharmacy, hospital pharmacy. In the other hand, due to the accreditation exams, and then you can work in a pharmacy, which could be in the city, in the countryside, you can choose. And then most of people can work also in the research, or sometimes with major industry, pharmaceutical industry, like Angelini, and then pharmaceutical companies. Yeah. Yeah, that's the main shoes you can do that. The main usually from rules think about pharmacy like the one the pharmacy like but now there is a lot of protest for that because the pharmacists that are doing they now they don't want to work there because they really less respect other countries. So it doesn't work for someone who studies so much. So usually they choose to go in some company or to go on studying or in hospital.
Perfect.
And from all online people, can you tell something about what do pharmacists in Italy? Okay.
That's okay.
Okay, it's okay.
I'll just summarize what our members here said. So essentially, we have the pharmacies that can either be in the city or out in the country. After pharmacy school, you can go on to do the residency and work in a hospital. But some pharmacists don't want to work in the pharmacies anymore, potentially due to the salary. So they're more moving into working for pharmaceutical companies and potentially doing clinical research. So a lot of that is very similar to the United States, and we'll kind of talk about what is similar and what's not. But because the majority of pharmacists do still work in what we considered the retail space, and so that's what you guys call your pharmacies that are likely in more of like the city setting. So pharmacists there, what do? So they provide access to the medications that are prescribed to them. They give advice to really promote the safe and effective use of the medications. So every time you get a new medication, likely you're asked if you have any questions about it, and the pharmacist educates you on how to take the medication, when to take the medication, things of that sort. They help with, in the United States at least, they help with insurance companies, which can be pretty troublesome for us. They educate on over-the-counter medications, so medications that you don't need a prescription for, but that you might still have questions about. Pharmacy technicians, they supervise them. They obviously keep the inventory of the medications in the pharmacy. I'm not sure about your pharmacists. Our pharmacists in our pharmacies provide vaccinations. And then we also have students that rotate through our retail pharmacies that are pharmacist precepts. But what do they not do? So they aren't at the point of when the decision is made what medications should be prescribed to the patient. So they aren't able to provide that advice before the medication is prescribed. They don't typically recommend discontinuing medications. That is more of a physician recommendation. They don't educate on how to take all of the medications. Typically, they educate on how to take that one new medications, but when we look at potentially the incredibly long list of medications that patients are on, they don't educate on how to take them all if there are any interactions with them. Sometimes our medications require laboratory monitoring. If we think about warfarin, their INR, if we think about levothyroxine, what is their thyroid hormone doing? So they aren't able to recommend laboratory monitoring for these medications. And based on the laboratory monitoring or laboratories that a patient gets back, they often aren't able to see them and recommend how to adjust the medications. And so there's a lot of medication therapy that we're missing in this retail space. And so why is this a problem? So we know that 90% of chronic illnesses that people have nowadays do require medications to treat. I will admit, sometimes we do overuse medications, especially in our elderly patients, that can lead us to some adverse drug events, but a lot of chronic illnesses do require medication therapy. And 1.5 million people are injured by medications that we prescribe every year. And that's a lot of patients. And we spend a lot of money on medications. $300 billion a year are spent on medications. And $290 billion are spent on treating problems that are created by our medications. So these are potentially big problems. So how do we solve these problems? We need to place the medication expert, i.e. the pharmacist, at the point of medication selection, purchasing, and the long-term management. So how do we do that? So there's 3 areas of what we consider clinical pharmacy that address these issues. So we have our clinical pharmacists that work in the hospital. And when we think about this, we think about the pharmacists that work up on the patient care floors within the medical teams and are really involved in those therapy discussions. So those are the pharmacists that can help us with the medication selection. And then in the United States, we have residencies that train pharmacists to be administrators. So in the hospitals, these are our pharmacy directors, our pharmacy managers, and these pharmacists are in charge of purchasing the medications. They're in charge of seeing where they can get the lowest price for medications. They keep our medication inventory. So they help us save money on our medications. And then we have our ambulatory care, or what we call our primary care pharmacists. So these are pharmacists in the outpatient setting that work in clinics and talk to patients about their medications on a regular basis. And so they look at all of the medications that a patient is on and have those discussions about potentially discontinuing medications. They have access to the laboratories of the patient, so maybe they can advise adjusting the medications based on the clinical picture of the patient. So these are three fields of what we call clinical pharmacy that can help address the problems with the adverse events of medications, the cost of medications, and then the long-term management. So these are kind of all of the different fields of pharmacy that we have in the United States. So we talked about clinical, working in the hospital. We have two kind of types of pharmacists that work in the hospital. We have our centralized pharmacists, which kind of sound like what your pharmacists do in hospitals here. So they work in our central pharmacy and really handle drug distribution out into the hospital. And then we have our decentralized clinical pharmacists, which those are the pharmacists who are specialized and work in the medical teams with the patients at the patient bedside. Like I said, we have our administrative pharmacists that handle all of the drug purchasing and drug management. We have our ambulatory, like I said, they work in the physician offices outpatient and really take care of long-term medication management. We have our community pharmacists, which are like your pharmacists that work in the pharmacies. And then we also have pharmacists that go into industry or work for pharmaceutical companies, just as you do. So today we'll really focus on the clinical pharmacies and pharmacists. And when we think about that, I'm going to be talking about those that work in the hospital and are decentralized, so specialized pharmacists. So how do you become a clinical pharmacist in the United States? So you do your high school training after you're done with middle school, elementary school. High school is typically 4 years long, and then you go to college or university, which is typically 3 to potentially 5 years, and then you pick a specialty. Some colleges do have pre-pharmacy as a specialty, but most schools do not. So we usually pick something in like biology, chemistry. I majored in microbiology. And then after you graduate college, then you go on to pharmacy school. Pharmacy schools in the United States are either 3 years long or 4 years long. And that depends on whether or not you get your summers off or whether it's a continuous cycle of pharmacy school. And then if you do want to specialize and become a clinical pharmacist, then you go to residency training. So residency training can be either 1 year or 2 years, and in the next slide we'll talk about why. So total, starting with high school, it typically takes about 12 to 14 years to become a clinical pharmacist in the United States. So what did I do? So I went to Xavier for high school, and then I went to Arizona State University for my college, my undergraduate degree, where I got a Bachelor of Science in microbiology. And then I went to pharmacy school at the University of California, San Francisco, and that was a 4-year school. And then I went back home to Wisconsin and went to the University of Wisconsin for my first and second years of residency. And I will point out that our 2 years of residency are paid. So they're paid years of residency. So I took 15 years to get to the end of my residency because I spent an extra year in college, but that was my path to get where I am today. So your clinical training really does start in pharmacy school. So your first through third years of pharmacy school, we have what are called our introductory pharmacy practice experiences. And so each one is a month long, and you have one during your first year, your second year, and your third year. And the purpose of these are really just to expose you to the different kind of large categories of pharmacy practice. So you have to do one in the retail or outpatient setting, you have to do one in the hospital, and then you have one as an elective. So some electives could be clinical trials, so learning more about the research of pharmaceuticals. You could go to a pharmaceutical company. Others would be working in the perioperative pharmacy. So you do have an elective to kind of pick and choose. And then your fourth year of pharmacy school, your didactic training is all finished. So you're no longer in the classrooms, you're not taking any sort of testing. You are just on what we call our advanced pharmacy practice experiences. And these are typically all within the hospital, except for one or two that you could do outpatient if you've identified that outpatient is an interest of yours. So they're all 1 month long. So during your fourth year, you rotate through about 9 different pharmacy settings. So you get a lot of exposure to different pharmacy specialties. You really learn about different medical conditions, things of that sort. And then after you are done with your advanced pharmacy practice experiences, that's when you take your pharmacy licensure exam, and you can either just start practicing pharmacy. If you work in the retail or within a pharmacy, you can just start working, or then you would go on to your residency training. So when we look at residency training, like I said, you could do 1 or 2 years. If you want to just work in a hospital or an outpatient clinic, you likely only need to do 1. But if you want to work in a hospital and specialize in a certain patient population and you want to work within the medical team, then you'd have to do first and second year. So when we look at first year, it really, again, is just giving you knowledge of the different fields of pharmacy. So you have required rotations, again, a month long, and typically the required rotations are like general medicine, transplant, oncology, critical care, really just to expose you to a broad array of patients. But because you're working in a hospital, you are also exposed to different diagnostics. You learn how to interpret laboratories. You learn how to read about imaging. You really learn how to put the patient picture together that helps you determine the best treatment options. And so when we look at first year residencies, I just kind of wanted to give you guys some statistics so you have an idea of how many programs and how easy it is to get a residency in the United States. So last year, these are the statistics for 2022, there were 1,470 first year residencies available. There were about 6,500 pharmacy students who applied for a first year residency. Out of those, 4,100 matched, and so the match rate was about 77%. So about 30% of pharmacy students who were looking to do residency did not get one. So it is fairly competitive, and you definitely have to interview for the residencies. And there's more and more pharmacy schools opening, more and more pharmacy students. So I can only imagine in the future, it will be even more challenging to potentially get a residency. So when you, after you complete your first year of residency, hopefully if you want to specialize, you have identified which specialty that you want to continue on to, because you do have to apply for the second year while you're still in your first year. But moving on to the second year, so this is really when you focus on one specialty and learn a lot about that. You work alone in your specialty and kind of have oversight from the pharmacist, but you really build your independent confidence working in this area. So for me, I did emergency medicine, so I spent most of my time in the emergency department. But you also have to learn a lot about critical care, because the patients that you really are focused on in the emergency department are those with critical illnesses. And so I rotated through the neuro ICU, the cardiac ICU, the surgical ICU. I spent 3 months in the emergency department. But in the United States, emergency medicine pharmacists are also very much seen as toxicologists. So I also rotated at the Poison Control Center in a toxicology rotation. And like I said, during your second year of residency, you do work independently in the setting that you have chosen. So I worked 8-hour shifts independently in the emergency department to really see if I could do it. So it's kind of a stepping stone from training to being independent. So for second year residencies, there's about 802 of them in the United States, so far less than the first year. There were 1,100 applicants, 814 matched, and so it had a little bit higher of a match rate of 82%. So still not a shoo-in, but a higher match rate. Any questions about pharmacy school training or residency training? I didn't mention it, but the second year residencies that are available, examples would be oncology, transplant, pediatrics, infectious diseases, critical care, psychiatry. We have some that are like pain management. There's just a wide variety of different residencies. And oftentimes, so for example, when I went to the University of Wisconsin, they did not have an emergency medicine second year residency. And so I had to apply for one and apply for the funding. And so we created it as I was there. So there's also the opportunity to do that if they don't have the specialty that you are looking for. And this is my first year residency class. If you don't recognize me, this is when I was blonde and excited. I was in the front with a big scarf. But as you can tell, we have a very large PGY1 class. And so kind of mixed in our class was our administrative residents. So we had a total of 8 administrative residents. So those are the pharmacists that want to become managers and directors and really handle the drug budget. We do have one outpatient pharmacy resident. We have one specialty pharmacy resident, and so he learned about all of the high cost medications that are given in the outpatient setting and how to kind of handle those drug budgets. We have an informatics resident, and so there's just a wide variety of things that pharmacists can specialize in the United States. And then this was my my class of second year co-residents. So I kind of put our specialties. So obviously I did emergency medicine. Erin in the back did infectious diseases. Louisa did primary care, so she works in the ambulatory space. She just started specializing in geriatrics. Amanda is transplant. Eileen in the back did critical care, and then Emily in the front did oncology. So these were the second year residencies that were present at my hospital. And again, this might not be the same as the hospital down the road. They might have more or less. It's just how many residents that they can handle and what patient population is present at their hospital. And another really cool thing about residency is you become really good friends with your co-residents. So every year, my co-residents and I do a trip together. So the big picture is when we went to Pittsburgh and went to a hockey game. The top picture is when we visited Chris in Portland, and then the bottom picture is when we went back to the University of Wisconsin and went to Louisa's wedding. So we stayed very close, and it's because we did both years of residency together. We all stayed at the same hospital. And something that we do in the United States is we now have the opportunity to become board certified. So when you think about different physicians, they do become board certified in different specialties, right? And what board certification is it really puts trust in the public that you know what you're doing, right? You have passed a test, you have proven that you know the information. And so pharmacists have acknowledged that this is important for our colleagues to trust us. And so these are the different board certification tests that are available in the United States. You might have seen on the first slide, I have the first one. It's board certified pharmacotherapy specialist is what BCPS stands for. And you can take that after your first year of residency. The third from the bottom is board certification in emergency medicine pharmacy. That is actually going to be available starting in May. I've helped create the content for that, and so I'm really excited to take that next so I can become board certified in emergency medicine. But this is just a really exciting kind of step for pharmacy so that we're acknowledged as clinical specialists within the medical team. All right, so what are some clinical pharmacist activities? So when I think about our activities and what we do throughout the day, we have both our direct patient care activities and then our indirect patient care activities. So I'll start with our direct patient care activities. And the first thing that I'll kind of talk about the progression of clinical pharmacy practice, and it's pretty similar to what I described in my last lecture. So if this is repetition, I do apologize, but it's kind of throughout every field of pharmacy. This is how we got to where we are today. But the initial activity that pharmacists were involved in the hospital was performing medication histories. So that was the most obvious sort of action of the pharmacist, was to talk with the patient about their medications. what medications were they on, and then to enter the medications into the patient chart so that the physician knew what medications to order and if all of the medications were safe. However, we found that pharmacy technicians and pharmacy students performed medication histories just as well as the pharmacists do. So then we thought, well, why don't we allow technicians and students to perform this task so that we can advance to more clinical skills where we are part of the care team. So we have what we call pharmacy extenders. And so these are technicians or students that go do things that pharmacists would otherwise be doing that we oversee. And so they'll go do a medication history, gather all of the information, put it into the patient's medical record, and then we will review it and co-sign it. So we still see what they're doing, but we are saving the time and actually performing the task. Other things that pharmacy extenders will do, we do medication reconciliation at the time of hospital admission, but it's also very important that patients know about their medications when they leave the hospital. And so it's a really, I think, important activity for pharmacy students is to counsel patients on their medications when they leave the hospital, because these are likely new medications. And so it's giving the pharmacy students practice in discussing new medications with patients. It's helping them improve their communication skills and really just getting comfortable having that one-on-one conversation about medications with patients that will then also extend to their conversations with the medical team and their comfort doing that. We also have a program called Meds to Beds. And so oftentimes patients are too ill to pick up their prescriptions at the pharmacy. And so we actually fill the prescriptions at our outpatient pharmacy and then bring them to the hospital bedside. And so we essentially deliver the medications to the patient before they leave the hospital. And then they also review medication costs. So when a patient is prescribed a new medication, because our insurance companies are not the best in the United States, we ensure that the patient is able to pay for the medication before they leave the hospital. Because if it's too much money, the patient is not going to pick it up, we're not going to know about it, and then their condition might worsen. And so we want to make sure if we need to provide a different medication before they leave the hospital, that we do. All right, so this is kind of the beginning of where clinical pharmacy started. So the Joint Commission, which is our national hospital accrediting body in the United States, they updated their medication management standards to say that all medication orders had to be reviewed by a pharmacist for appropriateness before they were dispensed out to the patient. And so because every single medication ordered by a physician had to be reviewed and verified by a pharmacist, they needed a lot more pharmacists in the hospital to review these orders. So this was really where the expansion of clinical pharmacy in the United States started. And so what else was the progression of the clinical pharmacist in the United States? So first, because we know the majority of medication errors is just due to lack of knowledge and information about the medications. And so clinical pharmacists started providing medication information and advising physicians about the medications, in addition to the order verification and review that was required by the Joint Commission. And so however, they were still typically in the central pharmacy, and so providers would just kind of call them and ask questions if they had them, but they still weren't really seen throughout the hospital. And then this progressed to the pharmacist doing the daily rounds with the medical team, because they decided that it took a lot more time to call the pharmacist versus having the pharmacist within the conversation so they could ask the questions and provide the advice right as they were thinking about the patient. And then we also, as we were at the bedside, started doing more patient education, talking to the patient about the medications that we were discussing so that they knew what was happening with their own care. And then once we kind of built those relationships with the care team, then we started being more of the medication stewards. We started having more opinions about what was being ordered. How can we save cost? What is the absolute most appropriate medication? We became more particular about what medications were being ordered. And so in order to do this, we started making treatment protocols. We outlined what the most appropriate treatment was and what could be ordered. And we'll go through some of the protocols in a bit. And then after that, we started teaching. We started taking on new students. We started teaching others about our field, not only pharmacy students, but also medical students. We take medical students in the emergency department and teach them about toxicology, teach them about medication toxicity, things of that sort. So it wasn't just in the pharmacy field, but we were doing multidisciplinary education. And then also clinical research. We do a lot of research within the hospital as well. Most of the research projects that we do are quality improvement, making sure that the care that we're providing is the safest and most appropriate. But sometimes it is more bench work. Some people like doing more of those microbial testing. So it's a wide array of clinical research that pharmacists are doing in the hospital these days. But this is sort of the progression of the clinical pharmacist, and the clinical pharmacist nowadays does all of these things. So any questions about any of these activities that we do throughout the hospital? Anyone online?
For example, about what are you doing for patient education?
Patient education?
Yes.
Sure. So every day the physician group goes to each patient bedside and they talk about what happened overnight, what sort of laboratories came back, what sort of imaging came back, and if there were any new medications that are being ordered. And so the pharmacist is present in those discussions, and so they will then take time and talk to the patient about what this means. So what medication we're adding, why we're adding it, and we kind of just bring it down to the patient level so that they understand what is going on within their care. And that might not be to the patient. The patient, say, might be elderly and not really able to understand. So we will talk to the family members. Sometimes we call the family members. We'll talk to the caregivers. And then at the hospital discharge, as I said, either the pharmacist or the pharmacy extenders will then educate on all of the medications. And sometimes where I did residency, we actually made a chart that talked about each time of day and when they should take their medications, so that they had that to take home with them, so that they understood exactly what they were supposed to do.
For people in patients or outpatients?
So that depends. I didn't spend much time in the outpatient pharmacy, so in our retail pharmacy, like your pharmacies, they do not, but we have the ambulatory care pharmacists that work in the physician office as outpatient. Sometimes they do a lot of patient education and a lot of making those charts, and sometimes they'll even fill the pill boxes for the patients. They're very hands-on in sort of the long-term management of the medications.
And also, can you give us some example of your role in the bedside patients at care grounds?
Mm-hmm. Yes, so independent of sort of the specialty or where the patient is, this happens on general care units, in intensive care units, everywhere. Every single patient is seen by the entire care team every day. So I have a photo in a few slides, but the care team consists of the attending physician, who is the ultimate sort of decision maker. And then you have your physician residents. So those are physicians who are done with pharmacy school, but in residency. And then you have your pharmacist, and then you're a pharmacy resident, typically, potentially also a pharmacy student. And then we also have a case manager, or a support staff that ensures that the patient can go home safely. If they need rehab, they pick what rehab they can go to. And so we're all assessing the patient every single morning. We're looking at what laboratories came back that day, what imaging came back, how are they doing mentally, physically. And so we all discuss the patient as a whole and decide what else we need to do that day to ensure that they're progressing to the point that we want them to.
And the pharmacist working in the ward is only working the ward or also in the central hospital pharmacy?
That's a good question. So the question was, the pharmacist who works on the floor or in the ward, do they also work in the central pharmacy? And they do not. They are up on the patient care floor all day long. And then we have pharmacists that are just in our central pharmacy. So I think it probably differs here. The pharmacists who work in the central pharmacy They do different things depending on the time of day. So the central pharmacists who work during the day are more in charge of medication distribution and bringing new medication into the pharmacy, because the pharmacists on the patient care floors are verifying all the orders, versus at nighttime, all of our ward pharmacists are gone. And so the central pharmacists are then in charge of the medication order review and verification.
Another is the relationship between with the doctors in the world, in order to medication advising, for example, which is this connection
with the providers.
Yes.
So we provide medication advice throughout the entire patient discussion, and during our discussion we read every single medication that the patient is receiving, and if we think it's appropriate, if we think it can be adjusted, if we think it can be discontinued. And so we physically look at every single medication on every patient every day.
Sorry, the audio is off.
È bloccato di nuovo.
This is.
Is it working?
Yes, now it's working.
Oh. Can you hear me now?
Yes. Yes.
Perfect.
Can you ask until when they was able to hear?
Oh, what was the last thing you heard?
The description of the team that you are now showing.
Okay, perfect. So this is just kind of a visual of what the team may look like. The nurse is an incredibly important part of the team, as they are with the patient all day, every day. And so they join our conversation and they update us on how they feel like the patient is doing. So this is really a multidisciplinary conversation about every single patient every day. Oh, yes. All right. So I just wanted to show you what the emergency department at Massachusetts General looks like where I work. This is just one little section of the emergency department that we call the acute section. And it's where the most critically ill patients go if they come to the emergency department. And I just wanted to show you this. You don't have to read what's in the little boxes, but I wanted to show you kind of how we all sit in the emergency department and show you that we're very much collaborating and openly discussing patients as they come. So I've put in the red boxes where all of the different specialties are. So you can see the EMMD, those are our emergency medicine physicians. They sit right next to the nurses and right next to our physician assistants. And then right next to them, and this is all an open space, so we're all talking, is the pharmacist, the trauma physician, and the respiratory therapist. And so when a patient comes in to the emergency department, I get up and go with the physicians to go listen to why the patient is there. I look at the vital signs, I discuss what I think the best treatment options would be. So I'm involved in that therapy discussion from the start. And if the patient is critically ill and needs a medication emergently, I go and get the medication, prepare it at the patient bedside, and give it to the nurse so that it can be administered as quickly as possible. So we're very hands-on, we're very much in the therapy discussion. So I just kind of wanted to show you what that looks like.
Sorry, I have a question.
Yes, please.
So you can you can change a medical prescription, so you can prescribe some medicine or therapies to the patients, or you need the medical consultation or something like that?
So that's a good question. A lot of the orders that our physicians give are verbal orders because sometimes they don't have time to go back to the computer to physically enter the medication. And so if they tell us that they would like the patient to receive a medication and we agree that it's appropriate, we can enter the medication into the patient's chart. We don't do it without discussing it with the provider. So we don't have like privileging to just order medications on our own. But if we are in the discussion, we all decide the patient should have a certain medication, the pharmacist is able to put it in the computer.
So in case of a wrong dosage or a wrong prescription or something like that, the fault is not the fault, but the wrong part is for the doctor or for you. So which is I can explain it in English properly, but in case of a wrong dosage, which is the fault, I don't know.
Are you saying if it's a wrong dose and the pharmacist medication?
Yeah.
Hopefully that wouldn't happen since the pharmacist is entering the medication, but if they do, it would be on the pharmacist because we can co-sign the medication order to the provider, but they don't have to sign it before the medication is given. So so if we entered an order and it was wrong and it was given to the patient, it would be our fault.
Okay, thanks.
Yep, exactly. Whenever a patient comes in, you are essentially doing everything that the doctor is doing. You are going to see the patient, you're talking about the diagnosis, you're looking at the imaging, you're looking at the laboratories, and you're constantly reassessing the patient. So I usually go to every patient every hour just to make sure their clinical condition isn't changing, if I think that the medication we're giving them is working. And so it's constantly reassessing the patient as well. Any other questions virtually? All right, so that was our direct patient care activities. So what we do at the patient bedside. Now we go into our indirect patient care activities. So these are sort of how we advance our practice, but not at the patient bedside. So a lot of this is in teaching. So we do a lot of multidisciplinary teaching throughout the day. Our Harvard physician residents have a weekly conference that they learn about different disease states. And every week, 1 hour out of their conference, we have me or one of my emergency medicine colleagues give a lecture about the medications to use, about whatever disease state that they are learning about. We have our nurse practitioner conferences that we teach at, nursing grand rounds. Nursing grand rounds used to be more formal. Now we do them right in the middle of the emergency department. We have pharmacy grand rounds, we have local conferences, and then pharmacists also have national conferences that usually each organization, it happens once a year. And so thousands and thousands of clinical pharmacists go to these conferences, and it's like 4 days of learning. And so you can present at these conferences, you have to submit a proposal, and it has to be accepted, but you can present at them if that is something that you'd like to do. We precept, so we precept both pharmacy students, we precept first and second year pharmacy residents, and then we also, like I said, we precept physician residents when they're on their toxicology rotation. So we have a lot of learners with us throughout the day that we are teaching. And I think the emergency department where I work is a really great place to teach learners because it's so busy that they just see so many things. And so it's a lot of active teaching. It's not so much sitting down and having a lecture. We do it at the patient bedside. So a patient comes in who is hypotensive. We talk about why we think they're hypotensive, what we think the best medication is to give them. So it's a lot of direct patient care teaching, which I think is the most effective because they actually see the medication given and what the patient's response is. Yes. So that's a good point. The question was, can you go to these conferences if you are still a student? So a large part of the people that go are students because that's where the residency programs advertise. So then you can talk to the current residents and see what the program is like, see if the people at the program are people that you could get along with. And so there's a lot of pharmacy students at the conference as well. The only problem as a student, you probably have to pay for it yourself versus as a pharmacist, your hospital likely pays for you to go. And then mentorship is really important to me. I had really amazing pharmacy mentors when I was in pharmacy school. And so we have a longitudinal advanced practice experience, 4th years, and I am a mentor for one of them. I'm also an advisor for one of our first year residents, and then we do have a 2nd year emergency medicine pharmacy residency for which I'm the director of. So a lot of kind of indirect patient care activities that we're doing throughout the day as well. We are also on different hospital committees. And I will point out that all of these committees listed, I am either a member of or a chair of, and they're multidisciplinary. So these committees consist of physicians, nurses, physician's assistants, pharmacists, because everyone's opinion is important for patient care because everyone has a different specialty. So the Emergency Department Operations Committee, this is where we talk about all the different patient populations, if we have new treatment protocols that we want to approve, things of that sort. I'm chair of the Pain and Palliative Care Committee, so what sort of pain medications can we use throughout the hospital? What sort of restrictions should we have on them? Like things of that sort. I'm a member of the Substance Use Steering Committee, so are we treating our substance use population appropriately? Do we have the services to help them treat their addictions, things of that sort? We have a stroke committee, a geriatrics optimization committee, and then I also lead the medication reconciliation task force that is composed of those pharmacy extenders that we talked about. So a lot of different committees. We're very busy with these indirect patient care activities. All right, so any questions about teaching, any of the committees, any of the indirect patient care things that we do throughout the day? And I'll point out that these committees don't meet every day. Each committee usually meets about an hour once a month, so it's not too much time spent.
Question should be about toxicology. Only pharmacist or pharmacist together with the doctor?
So the pharmacist, not the pharmacy student. The pharmacy student, if they are on rotation, they can listen in on the toxicology discussions, but we currently don't have a toxicology rotation in the emergency department. The Poison Control Center does have a toxicology rotation that students can take. And this isn't a common thing, it's just that one of our emergency medicine pharmacists did a toxicology fellowship instead of residency, and so he's actually a toxicologist as well. And so he's the one that leads that rotation for the physicians. All right, so we'll move on to a few of our treatment protocols. Yeah.
About the geriatric staff.
Sorry, we can't hear you.
Yes, okay. It's okay.
Can you hear me now?
Yes.
Yes.
Okay, perfect. Sorry about that. But the pharmacy side of the geriatric task force is we make what are called order sets. And so these are things in our electronic medical record that when a provider types in, say, geriatric agitation, a list of medications come up that are most appropriate for them and lower doses that we want to give our geriatric population. So we create these order sets, so it's easier for the providers to pick safe medications and safe doses for this population.
This is only in a specific ward or for all hospitals in emergency department, because you know that Shan Yu, for example, is working with you.
Yes, so
Shan Yu, can you explain?
Yeah, so Shan Liu is a emergency medicine physician who came to Pavia, I believe, last year, and lectured. And so I work with her. So I showed you the diagram of where we sit. So I sit right next to her in the emergency department. And she's involved in a lot of clinical research. She does a lot of research. Mara Kennedy is the physician who leads the task force. So she's an emergency medicine physician that specializes in geriatrics. So this task force is just specific to our emergency department and our emergency department observation unit. But I don't know if there's a separate committee hospital-wide, but this one is just for emergency medicine patients. And her most recent kind of project through the task force was making sure that all of our geriatric patients were getting screened for delirium as soon as they entered the emergency department. Just because delirium can present on such a wide spectrum, most of the delirious patients are actually hypoactive, and so we miss that a lot of the time because we just think that maybe they're tired, maybe they are just sick and not very interactive, when they could actually be delirious. I talked about a statistic yesterday where about 40% of nursing home patients that present to the emergency department are delirious. And we know that when we don't recognize delirium, it increases their mortality. So now when a patient comes into the emergency department, the nurse has to go through a delirium screening. So that's something that this task force added to the patient's assessment. All right, moving on to treatment protocols. So this is an example of a treatment protocol for sickle cell disease. I don't expect you to see it, it's pretty small, but essentially what it does is we had physicians and pharmacists working on this protocol, and part of it is the initial assessment. So what labs should you get on a sickle cell patient that presents with a pain crisis? What imaging should you get? And then the pharmacy side that we created was what medications should you initially order on your sickle cell patient? So we describe doing a multimodal approach. So you should prescribe Tylenol, ketorolac, low dose or high dose IV opioids. We talk about how frequently to re-dose your opioid, how to de-escalate from intravenous opioid to oral opioid. And so it really just helps the provider easily look at what they should initially be ordering in order to treat these patients appropriately. So again, this was a multidisciplinary effort to create an easy to read, if you actually have it in person, an easy to follow sort of treatment protocol. And this is something that could be made into an order set, but this is fairly new, so that would take a while. But just an example of the treatment protocol. And then as I was explaining in my last lecture, what we try and do is after we've made a treatment protocol, we publish about it. So not only do we want it to be available to physicians, pharmacists, anyone at our institution, but we want it to be available to anyone in the world who is treating these different populations. So I published my paper on sickle cell disease in the American Journal of Emergency Medicine, and so I talked about what antibiotics these patients might need if we're worried about acute chest syndrome. What is an example of a pain control regimen up front? So this is kind of what we do with our treatment protocols. We create them institutionally and then we publish them nationally. And this is another protocol that we use pretty frequently, which is our severe alcohol withdrawal pathway. And so again, this really just tells physicians what the safest options are. So typically with our alcohol withdrawal patients, we will start with our benzodiazepines, and at Mass Gen, we typically use lorazepam. But if your patient isn't responding to the benzodiazepine, you might need to escalate to something like phenobarbital. And we'll have this kind of in our patient case later on. But how much phenobarbital should you give your patient? Are they at risk for oversedation because you already gave them too many benzodiazepines? And so this treatment pathway breaks it up based on risk of sedation. So you give little boluses of phenobarbital or you give the big load. We tell them how frequently to reassess their patient, how frequently to redose. And if the phenobarbital doesn't work, what are kind of your last line agents? So again, this is just an easy to find, easy to use treatment protocol to really take that guessing game away from the physicians so that they can treat their patient quickly, most appropriately, and then move on to doing other diagnostic things that they're best doing. This is again an example of a treatment protocol, and this one is for severe agitation. This one we break it down into age group. So is your patient pediatric in the yellow? Are they an adult in the green? Or are they geriatric in the red? And for geriatric patients, we further break it down into why are they agitated? Do they have an underlying psychiatric illness? Do they have dementia? Do they have delirium? Or do they have a Parkinson's disease? Because we know that we don't want to use first-generation antipsychotics in our Parkinson's patients because it'll worsen their movement disorders. So this helps the provider identify their patient population, what medications could be harmful, what dosages to give, what route to give. So we really pack a lot of information into our treatment protocols, but it saves everyone a lot of time and it helps us treat the patient as quickly as possible. And then, like I said, we took our protocol and published it nationally. So this is a paper that I wrote alongside Mara Kennedy, who was the emergency medicine physician who specializes in geriatric medicine. And this is just a helpful flow sheet for you to ask the questions that you should be asking when a geriatric patient presents to the emergency department agitated. So again, we just take what we do locally, publish it nationally, so everyone has the opportunity to learn from it. And as you can see, it's multidisciplinary. So there's 2 physicians on the paper, me as a pharmacist, and so we do publish and do a lot of research as teams. And so the physicians don't just do research together, the pharmacists don't. We really blend a lot of our knowledge to create the best publications and treatment protocols that we can. All right, and something that is really important to me, as I said, I am on the Substance Use Steering Committee, and so helping patients enter addiction recovery is something that I'm very passionate about. And so a service that we recently added to our emergency department is providing patients who present to the emergency department after an opioid overdose, but who are interested in recovery. We give them a Suboxone, which is the combination of buprenorphine and naloxone, to go, so that they have a 3-day supply that gives him time to enter an addiction program. So this is a ED to home with a supply so that they don't have the urge to go back onto the street and use heroin or fentanyl again and potentially overdose fatally.
We can't hear you from home.
Can you hear me now?
Yeah, thank you.
Okay.
Probably we can do.
I think it keeps going. So in order to, by law, dispense this medication from the emergency department, we have to add the patient information to the label, which we do in the emergency department. So the pharmacist physically writes the patient information onto the bottle. And then we've created this patient education document that tells the patient when they should start taking the medication, because we know that if they're not in opioid withdrawal before taking it, when they take the medication, it will put them into withdrawal. And we know that's incredibly uncomfortable, and they likely won't take the Suboxone again. So we tell them what signs and symptoms they should be experiencing before taking the medication, what dosages they should start taking, how often they should redose, and so, and also on day 2, what strength they should take. And so this really walks the patient through starting the Suboxone, which is the most important part about recovery. And we physically give this to them, sit there with the patient, and answer any sort of questions that they might have about the medication. So we use these protocols to also educate our patients. And again, as we always do, we published on the results of our treatment protocol. So this was a research project that was done by our emergency medicine resident last year. And we were curious about how many of the patients that we send out with this 3-day supply actually continue taking it for a prolonged period of time, which would tell us that they potentially continued on in their addiction recovery. So we had a total of 155 patients in our study, and we found that 70 of the patients, so 45%, continued filling the buprenorphine at 3 months, and then 41% continued filling the medication at 6 months. So almost half of the patients that we gave the prescription to continued taking it for a prolonged period of time, which we would consider a success for our program. And we also looked at how many of those patients that initially presented to the emergency department following an overdose re-presented after we gave them the medication again for an overdose. And only about 11% of them had a second presentation for an overdose in the 6-month period that we followed our patients. All right, any questions about our treatment protocols in terms of how we create them? If you have any questions about other protocols that we might have, or how we move the protocol from just institutional to being available sort of nationally? Do you guys make treatment protocols within your hospitals to help with prescribing? Oh, sorry. Sorry, which is the Suboxone? No, who benefits? Oh, the next slide, yes. I'll continue. All right, so who benefits from having clinical pharmacy services around? So we're there to really help the patients. We're there to make sure that they are getting the most appropriate medication, that their medications are being used safely, and that we continuously reassess if the patients need their medications. So polypharmacy, you've probably heard this word quite frequently, is a big problem in the United States. A lot of patients are on a lot of medications, and unless you see the patient, unless you know the medical history of the patient, you don't know if they're appropriate. And so really the patients benefit the most because they have multiple medications, multiple disease states. they're often going to multiple different prescribers to get their medications. And so the different doctors don't know all of the medications that the patients are on. And so we have the interest and the time to kind of dig deep and see who is prescribing these medications. The medications need frequent monitoring and dose adjustments. And if we're at the bedside, seeing what's happening day to day, we're able to recommend those adjustments. Geriatric patients, they are very different. They respond to medications very different. And so we can recommend different medications based on their sensitivity, different dosages at when we should redose the medications, and also the underserved. So we have different coupons that we can give to patients to help cover their medications. We can see what their medications are going to cost before they leave the hospital, so that we know when the patient leaves the hospital, they're getting the medication that we think that they should have. Doctors benefit. They benefit from not having to spend the time looking up medication information. They benefit from feeling confident that they're giving their patients the most appropriate medications and they're treating the disease states the best that they can. The nurses, we work very, very closely with our nurses. They are also very interested in medication information. I think oftentimes our nurses are just seen as people who administer medications, but they want to know what they're giving their patients. They want to know why they're giving medications to their patients. And so they really love having us around so that they can become more knowledgeable about what they're doing. And health systems. We save a lot of money having treatment protocols, having pharmacists at the bedside, making sure we're being most cost effective. So our health systems are saving a lot of money, and because we're using medications as safely as we can, we're decreasing our drug adverse events. Maybe the patients are not staying in the hospital as long as they potentially would. We're treating infections more appropriately, so they're getting better quickly. So patients, doctors, nurses, and health systems overall are benefiting from clinical pharmacy services. So where do I see the future of clinical pharmacy? I think we need to continue blending our inpatient, so our hospital pharmacy, with our outpatient. Patients should not have such distinct care when they enter the hospital and when they don't. So I think we need to talk more between the inpatient and outpatient side so that we know that the care is appropriate, independent of where the patient is. So I think our ambulatory care pharmacy practice needs to expand. So the pharmacists who are managing the medications long-term, whether it be an old medication or a new medication. And so this is really expanding our medication therapy management in the outpatient setting. Further integrating teaching into physician conferences and national committees. I've heard from our physicians that they want more education on medications. They want the medication experts to be teaching them the little things that we learn about in pharmacy school. So pharmacists should enter the physician and medical schools. They should go to the continuing education conferences of physicians because they want to learn about medications more than they currently are. And then creating more opportunities for international studies. I think it's phenomenal that Giovanni does this, and you hear about pharmacy practice outside of Italy. And I'm interested in what your pharmacists do. So I think having more opportunities and ability to move throughout the world and expand practice everywhere is incredibly important. So I'm so glad to be here talking with you all about this. All right, so that is at the end of just my overall talk about clinical pharmacy before we move into the patient cases. What questions can I answer?
I want to know more about the education system. So in Italy, we have 5 years of university, include masters. So after that, shall I do PhD in America if I want to study, if I want to study in America, or do pharmacy school and then do residency?
Yes, that's a good question. So for everyone virtually, the question was about our education system and the best way to train in America clinically. If you should stay here and do a master's after your training and then go to the US. So our residency programs, in order to be accepted, they have a requirement that you have to be trained at a US accredited pharmacy school. And so you would have to go to pharmacy school in the United States in order to match into a residency program. The residencies? The school. So it's either 3 or 4 years. There's a lot less 4 years now just because people want to get into the workforce faster. But if you want some of your summers off in order to explore different fields of pharmacy, then you'd go to the 4th year. If you're okay just doing it year round for 3 years, you could go to a 3-year. Correct, yes. So all of our, at this point in time, if you want to work within a pharmacy, you have to have at least 1 year of residency training. And in order to be accepted to a residency program, you have to graduate from a United States accredited pharmacy school. You have to do them all again? I'd have to look into that. I know people from the US that has transferred into different levels of pharmacy school, but that's a good question. I'm not sure about that. The question was, are there any courses from Italy that could transfer into the United States pharmacy program so that you wouldn't have to do all of the 3 or 4 years again? And I don't know the answer to that. Great questions. What other questions? I know that there are, I believe Australia, they have clinical pharmacy specialists, and I know in certain areas of Asia, they have like emergency medicine specialists as well. And they actually have more privileging than we do in the United States. I was talking about in my last lecture, they have what are called emergency medicine pharmacy practitioners, and they actually have the ability to independently care for a patient. So patients who present to their emergency department who aren't critically ill, they are able to order the laboratories, order the imaging, and order the medications. This is pretty new, but they are starting to publish on the safety of having pharmacists as practitioners in the emergency department, which I think is really amazing for our profession. But there are a few places throughout that do have specialties outside of the United States. Oh, any questions from anyone online? Should I check the chat? I see the question, how can an Italian pharmacist become a clinical pharmacist in...
How can an Italian pharmacist become a clinical pharmacist in America and USA? What studies should you conduct?
I think I answered that question, but if not, if you do want to become a clinical pharmacist in the United States, you would have to attend a US accredited pharmacy school in order to match into a residency program.
Other questions from home?
Other questions from home? All right.
Probably one question, I have another question. Clinical pharmacy, only for pharmacists working in hospitals or also for community pharmacists?
That's a good question. The question was, is clinical pharmacy just pharmacists who work in the hospital, or is it pharmacists who work outside of the hospital as well? So we do have what we call our primary care clinical pharmacists. So those are pharmacists who work in physician offices out of the hospital. And so when a patient comes to talk to their physician about any problem, these pharmacists will go into the room with the physician and obtain the medication history, talk about how they're taking their medications, if there are any changes that they need to make. And so those are the pharmacists who are considered clinical pharmacists. They do residencies, but they deal with more of the long-term management of the medications. No. No, in order to do clinical pharmacy, you'd have to go to residency after pharmacy school. You can just do one if you want to work, say, in the central pharmacy, like your pharmacists do here. But if you want to work up with the medical teams and have a specialty, then you'd have to do the second year. Correct. Yep, yep. Mm-hmm. Who wins? Yeah. And I think that's what I love about this job is, so the question was, what if the physician and the pharmacist don't agree on what to give the patient? And this is what's great about clinical pharmacy is having these discussions about what the best medication is. And so that's really where national guidelines come into play. That's where pharmacists are able to look at smaller studies and see, is the patient population in the study, does it match our patient? What were the outcomes? That's how we are able to sort of select the correct medication for the patient based on their organ function, based on their age, things of that sort. In the end, if the physician is very determined that the pharmacist's opinion is not the best, then obviously they would win because they are the provider. All right, any other questions? All right, moving on to our clinical cases. Sorry, take a drink of water. Okay, so moving through these clinical cases, I'm not going to spend a whole lot of time on like the diagnostics and things of that sort. I'm going to show you where a clinical pharmacist would intervene on these cases, where we would provide the medical team with knowledge, and how we might change the medications that a patient might get based on the advice that the pharmacist would give. Because I've obviously told you what the patients already have. We have a case about a pulmonary embolism, sickle cell, and alcohol withdrawal. All right, so case one is our sickle cell, and these are all patients that I recently had in the emergency department. So this is a 33-year-old female with sickle cell disease, and she presents to our emergency department in a pain crisis. She has tried to increase her home pain medications without improvement. She currently describes her pain a 10 out of 10. She was visibly in excruciating pain. You couldn't touch her, you couldn't do any sort of medical assessment, and she couldn't even speak in full sentences because she was in so much pain. We don't have any past medical history on her or any history of what medications she's gotten in the past because she always receives her care at a different hospital. So what sort of questions do you have for this patient? Yep, so what sort of medications have worked for you in the past? Sure, so did you recently change your medications that could be contributing to why you're in a pain crisis now? If she has what? Some illness? Exactly. So what have you tried before? What dose of that medication was effective? These are all great questions. And they are very similar to what I would ask. So I always ask, what are your medication allergies? Because that's important to see what sort of medications we can use. What have you tried in the past? Has anything been effective? And that's supposed to say what dose of medication is effective for you. So great, all the questions that you guys would have asked. So she says that hydromorphone and morphine give me an awful rash all over my body. So the doctor looks at you and he's like, okay, well, we can't use morphine. We can't use hydromorphone. What medication can we give her? What should I order for my patient to help control her pain? What would you guys recommend? Sure, so we know that she has a hydromorphone allergy and a morphine allergy. So these are the two that the physicians typically order for these patients, but we can't order for her. So the physician is like, I don't know what to do. What would you recommend? Yes, a medication without morphine or hydromorphone. So this is where your pharmacy knowledge comes into play and allows you to give the provider a recommendation right at the patient bedside. So we know that there's 3 different types of opioids. And so we know that there's the naturally occurring that we haven't produced in a lab at all, which is morphine and codeine. So we wouldn't use codeine anyway, but you know that those are out. There's the semi-synthetic, so we partially make them, and those are your hydrocodone, hydromorphone, oxycodone, and buprenorphine. So we know we likely can't use any of those medications as well. So we have to think about our synthetic class. So these are medications that we fully make in the lab. So we have our fentanyl, our methadone, and our tramadol. Out of those 3, what would you recommend for your physician? So she's only allergic to the morphine, which is naturally occurring, and the hydromorphone, which is semi-synthetic. Exactly. So we have to say, okay, she can probably only tolerate our synthetic opioids. So of those 3 options, is there one that you would recommend? So you have a patient who is in excruciating pain. You know that she's already on opioids at home, and so she can probably tolerate a good dose of opioids. You want something that's very fast acting. Would you choose fentanyl, methadone, or tramadol? So I would choose fentanyl. So methadone, we know, has a very long half-life, and so it takes quite a long time in order to see the effect of methadone. And tramadol is kind of like a partial opioid, so it's not as strong as, say, fentanyl. So fentanyl would be my first choice because it's rapid acting, it's very potent, you give it intravenously. And so she says, fentanyl is the only opioid that I can tolerate. And when she gets fentanyl, she usually gets it via a PCA, so patient-controlled analgesia. Do you guys do PCAs in your hospital? No. Okay, I'll show you the device that it is on the next slide. But essentially, it's a way for the patient, whenever they push the button, they get a dose of the medication. And so, you know, in the emergency department, our nurses are incredibly busy. And so this patient says the typical dose that's worked for me is 200 micrograms every 30 minutes. Our nurses don't have time to go administer a medication every 30 minutes to this patient. And so what a PCA does is it allows her to push the button herself and get the medication. So this is what it looks like. So the screen on the top, that tells you how much of the medication the patient is allowed to get. So we obviously don't want the patient to continuously push the button and get as much medication. And so we have what's called a lockout period. So because she said she gets it every 30 minutes, we have a lockout period of 30 minutes. So she can only push that button every 30 minutes. We can see that the drug is fentanyl, and then that little control is what the patient pushes. So she can get the medication without the nurse having to give it. And this is very effective for patients like sickle cell patients that need doses very frequently, especially right when they present, until their pain is more under control. All right, so the patient's pain went from 10 out of 10 when she presented to about 7 out of 10 in the first 6 hours of treatment. So by this time, it was nighttime, and she was able to get a little sleep overnight. However, the next morning, she endorsed escalating pain, so her pain was coming back. The PCA doses, so the dose that she was able to give herself, was increased several times during the morning without any improvement, but rather, she had continuously increasing pain. So what do you think is happening to the patient? And what would you, the doctor says, I don't know what to do. This is the only opioid that the patient can tolerate. We're giving her very high doses. We don't know what to do next. Have you guys ever heard of opioid-induced hyperalgesia? So this is something that patients who are typically on chronic opioids, it's usually not patients who you're just starting opioids on, can have. There's several different pain mechanisms that are suggested. It's not really known, but it's a phenomenon where you continuously escalate the opioid dose and it causes more pain for the patient. And so you should suspect opioid-induced hyperalgesia if the patient's pain is increasing without worsening of their actual disease state, and escalating doses of pain medication is actually leading to more pain. And so how to prevent this? So you want to reduce doses of the opioid and add on other agents, typically NMDA receptor antagonists, to help with the patient's pain. So we kept increasing the opioid dose and her pain kept getting worse. And so adding more opioid was worsening the patient's pain. So something that pharmacists in the United States see pretty commonly in our surgical patient population, and something that is in the back of our mind that is often not in the back of the provider's mind. So this is something that I thought, well, maybe she is experiencing this. So the provider's like, okay, I know what an NMDA receptor antagonist is ketamine. Well, the patient then tells you that she gets horrible hallucinations when she's been given ketamine in the past. So the provider's like, great, now we're back to the drawing board. What do we do next? I don't know what to do. And so this is, again, where pharmacy-specific knowledge comes into play. So one proposed mechanism of opioid-induced hyperalgesia is that it's more like a neuropathy sort of pain. And so we know that giving lidocaine and magnesium is effective for neuropathy type of pains and is also effective for overall pain management. And so for her, we decreased her dose of fentanyl and started her on a lidocaine infusion and a high-dose magnesium infusion, which was incredibly effective for her pain. And in about 3 days, we were able to titrate down all of these medications, put her on her home medications, and she went home. So as you can see, having the pharmacist at bedside in those treatment discussions was really helpful for this patient, because we were able to determine what sort of pain medications the patient could probably tolerate, being the fentanyl. She needed frequent dosing of the medication, so we knew that doing a PCA was probably the best. And then when the patient was experiencing worsening pain from her opioid, we knew what medications that are not very commonly used for pain could actually be helpful for this patient. So this is an example of where a clinical pharmacist at bedside could be very helpful. Any questions or comments about this case?
Probably they not to use it to use these drugs.
Mm-hmm. Yes.
Did you discuss it with the courses the use of these drugs?
In the hospital, right? Yeah.
But do you know, for example, ketamine and so on?
Mm-hmm. When you would use it, yeah. Even not knowing the medications, does it make sense where the pharmacist is important in these discussions? Lidocaine?
Side effect of
Oh, lidocaine is a what?
The problem is with the pain related to the analgesic effect.
Yes.
And also related to the side effect of the
Oh, yes. So lidocaine is obviously used for several different things, including like arrhythmias. It's used topically as an anesthetic, but we use low dose infusions because it actually does, when it blocks the sodium channels, it actually decreases the pain neuron firing. And so it decreases the propagation of pain throughout your body. Mm-hmm. PCA. Mm-hmm.
Actually, my question is, this instrument is for endovenosa?
Yes, intravenous.
Yeah.
Yes. Yes, exactly. So the PCA has your typical intravenous tubing out of the fentanyl bag, and it is connected to the patient's intravenous. So it's continuously connected. Mm-hmm. Mm-hmm. Any questions from home about this case before moving on? All right, so we'll move on to our case about a pulmonary embolism. This was a very interesting case that had a lot of different twists and turns to it, but this was a 43-year-old female. She initially presented to the urgent care, so not to the emergency department, and she was complaining of shortness of breath. And while in the urgent care, she actually had a witnessed tonic-clonic seizure. And this was odd because she didn't have any seizure history, and all she was complaining about was shortness of breath. When we looked at her past medical history, she has diabetes, PCOS, she's morbidly obese, she has depression, but again, no seizure history. When we look at her vitals, her oxygen saturation is 88 to 89%, so it's low. She is tachycardic with a heart rate of 140, and her blood pressure is pretty low in the 80s. She has had a cough and a right leg pain for a few weeks now. And so they were concerned about a pulmonary embolism, and so they sent her to our emergency department. When she arrived in our emergency department, she was still tachycardic, so she had a heart rate of 140. Her blood pressure was still low, but it was improving, systolic of 92/53. So the laboratories that we typically order for patients that were worried about a clot is the D-dimer. The D-dimer was greater than assay, and her lactate was 6.9, which is very high. So we know that there was some sort of ischemia going on and not enough blood flow throughout her body. So in order to see if someone has a pulmonary embolism quickly before we can send them to a CT scan, the physician did a bedside ultrasound, so right at the bedside, and he saw that her right ventricle was big. So when you have a large clot in your lungs, because your right ventricle is what is sending blood to your lungs, there's so much pressure from that clot that your right ventricle gets bigger. And so her right ventricle was very large. And so there's 3 different categories of pulmonary embolisms that patients get placed in, and this determines what sort of treatment we use. So we have our non-massive PEs, pulmonary embolism, and those are your patients who are hemodynamically stable, so their heart rates are fine, their blood pressure is fine, and there's no evidence of that right ventricular, what we call strain or enlargement. We have our submassive pulmonary embolism. These patients, their vital signs are still okay, but they do have signs of that pressure building up on their heart. And you can see that the mortality rate increases quite a bit from less than 2 to 15% in this category. And then there's massive PE, mortality rates about 60%. These patients have poor vital signs. They are on vasopressors. They are bradycardic, so their heart can't pump as much, and you have impending arrest. So these are your sickest of the patients. So finally, the patient got her CT scan done, and it showed a saddle PE. So saddle PE is a clot that's in both sides of your lungs. And again, it showed that right heart strain. So do you guys know how we treat pulmonary embolisms? So we have to use a blood thinner, right? So we have two different options. There's enoxaparin or Lovenox, and then there's heparin. We always joke that MGH stands for must give heparin because our providers always order heparin. And so of course our provider ordered a heparin bolus and an infusion. And this is where I said, hold on a second, is heparin the best agent for this patient? Because enoxaparin is actually the preferred anticoagulant over heparin in all of the patients for this submassive pulmonary embolism. And why is that? It is safer. It's showed in studies to have a lower risk of bleeding. It's more effective, and I'll show you why in the next few studies. You get therapeutic shorter. Heparin takes a very long time to reach the blood thinning levels that you want, and you don't want to waste all of this time while you have a patient whose blood pressure is low. They obviously have a large pulmonary embolism. So at Massachusetts General, we have this team of physicians that are called our Pulmonary Embolism Response Team, or our PERT team. And what they do when a patient has a pulmonary embolism, we call them and see what the best therapy would be. And so after creating this team in 1995, they looked at whether or not their therapy was actually effective. And so in this study, there were 716 patients that the PERT team was activated, and 70% of these patients were treated with the heparin. About half the patients had evidence of that right heart strain, so we're at least in the submassive category. 28% were classified as having high risk or massive, and then about 8% actually had hemodynamic collapse and potential arrest. So these were sick patients. So we saw that with the heparin infusions, only 13% of the patients reached the therapeutic goal after 6 hours. And only 35% reached the therapeutic goal after 2 days. So we saw that not a lot of our patients are actually being treated effectively with heparin. And so individuals that had low, so not enough blood thinning was more than half of the patients. And then some patients actually had too much blood thinning. And so we can see that heparin is not a great drug, and we don't reach the therapeutic range that we want to with this medication. And there was a second study that also looked at patients that were giving heparin, and they saw that it took at least 10 hours for the majority of their patients to get to the blood thinning that they wanted. And that's a long time. And so we as pharmacists know that heparin isn't the best drug for our patients, especially if we want more rapid blood thinning. But we also know when to use the medication. So it's best in patients who have renal dysfunction, who are potentially hemodynamically unstable going to surgery, or that we think we might have to give thrombolytics to, because we could potentially reverse heparin. So I was like, hold on, heparin might not be the best for this patient, and we had that clinical discussion. Well, while our PERT team was at bedside, the patient's blood pressure started dropping, and we started the patient on norepinephrine, which is a medication that helps increase the blood pressure. So now our patient moved from submassive into massive PE, so she got much sicker very quickly. And so we know when we manage a pulmonary embolism patient, there are 3 things that we need to really focus on. Early thrombolysis, so this is breaking up the clot very quickly. Decreasing the resistance in our lungs. So like I said, when you have a clot in your lungs, your vessels often constrict, and so you get a lot of pressure in your lungs, and that's what affects your heart. And so you want to make sure those vessels are less tight. And then you also want to support the patient's blood pressure so that it continues circulating throughout their body. So looking at thrombolytics, we have 3 different options for medications that bust up the clot. Alteplase and tenecteplase are the medications that we typically use in the United States. Our hospital recently switched to tenecteplase because it's much easier to make and administer. And so this is something that the pharmacist would get and mix at the patient bedside, and so the nurse could administer it as quickly as possible. So our patient actually had cardiac arrest. Her blood pressure dropped, she arrested. The pharmacist grabbed the tenecteplase, mixed it at bedside, gave it to the patient, and CPR was continued, and the patient had return of circulation. And so that was effective for our patient. And so now we know that the patient still has all of this pressure building up in her lungs. And so we need to decrease that pressure. And so two things we can do is break up the clot, as we've already done, and the other is to dilate the vessels in our lungs. And so how do we typically do this? So the two most common agents are nitric oxide, which you actually inhale, and epoprostenol. So epoprostenol, we think of a medication that it's a continuous infusion that we give to our patients with pulmonary hypertension. And so it's very expensive, and we don't have it in the emergency department. It would have to come up from our pharmacy, which in this case is too long. So our provider is like, what do we do? I need to decrease the pressure in this patient's lungs, but we don't have any of the medications to do that. And so that's where my knowledge of different medications comes into play. We have nitroglycerin in the emergency department, and we know that nitroglycerin dilates. And I know that you can actually inhale it. Typically, we give it intravenously. And so I recommended inhaling nitroglycerin until we could get the medication up from the central pharmacy. So this is, again, something that we can recommend at the patient bedside in order to improve the patient's care. It's a bit about the mechanism that I'll skip. And then we also need to increase the patient's blood pressure. Our patient, again, she did come back. We got her back after the tenecteplase, but she was still hypotensive. And so these are the different medications that we have to increase a patient's blood pressure. And so this is something that clinical pharmacists love to talk about. We love to talk about the different receptors that the medication hits. Does it affect the heart rate? Does it affect the blood pressure? And so we would recommend either norepinephrine or epinephrine off the bat. But we also know that vasopressin is the only medication that causes constriction, but not in the lungs. That's something that's not commonly known for physicians. And so those are recommendations that, again, we can make at bedside. And these are medications that we would mix at the bedside as well. And this is just a chart to kind of also that we've made for the providers to help them decide which of the vasopressors they would want to start first. All right, so that's our pulmonary embolism case. Any questions about that case? Again, it's really just to show you what sort of conversations we have with the physicians, what sort of recommendations we make, and where our true pharmacy knowledge comes into play.
So you mentioned a few steps that you said that they happen simultaneously, but I mean, is it like the fraction of time? Is it long time or like a short time that she decide what to do?
It's right away. So for her, we.
How do you know what to do to the patient? Like you already know?
No, so that's what you learn in residency. You just spend so much time with different patients, and you see how different situations turn out, how patients respond differently to medications. And that's why it's so important to be at the bedside, so that you see what happens after you give a medication. And so for her, we would give a medication. I would go out, look at orders, verify the orders. 4 minutes later, I would go back in and see how she was doing, seeing if she needed another medication. If she needed something fast, I would go get it. I would prepare it, give it to her, go out of her room, go do something else, come back. And so we're continuously evaluating the patient, getting different medications on board and seeing how they're doing. Mm-hmm. Any questions from home?
I really have one question. Waiting the question from online people. Okay. You mentioned also, do you use also low molecular weight heparins?
Yes, so that's the enoxaparin, is the low molecular weight heparin, which is preferred over the unfractionated heparin.
And can you explain to the students the difference between dopamine and dobutamine, and why you use dobutamine?
Sure. So there's differences between vasopressors and what we call ionolators. So dopamine I can go back to my handy little chart here. So dopamine, depending on what dose you use, so there's like low, medium, and high dose dopamine. I don't truly believe in this. I think that it hits all of the receptors at all of the doses. But the theory is that at low dose, dopamine only hits the dopamine receptors and increases the blood pressure by increasing volume. If you do the middle dose dopamine, which is the 5 to 10 micrograms per kilogram per minute, that hits your beta-1 receptors. And what that does is it increases your heart contractility. So if you, this is frequently used in patients who have heart block and their heart rate is dropping and you want to increase their heart rate, you would use medium dose dopamine to really increase their heart rate. And then at the high dose dopamine, which is the 10 to 20 micrograms per kilogram per minute, it hits your alpha-1 receptors, which causes constriction throughout your body. So that's what increases your heart rate. So at the high dose, your blood pressure. At the high dose, it'll increase your blood pressure and your heart rate. Dobutamine is it only affects your heart rate, not your blood pressure. But dobutamine does hit beta-2, and so it can actually cause dilation a little bit. But it's used for patients who have like heart failure that aren't getting enough blood out to the body. And so dobutamine helps increase what we call our cardiac output, versus dopamine just increases like your heart rate.
And about practice, the decision to use this drug or another drug is from consultation between you and the doctor, or only the rest of the doctor?
Like who selects the medication? Oh, yes. So
especially in this acute emergency situation.
Yeah, so we talk about it. So our providers typically like norepinephrine for most patients. It's great in your septic patients. It's good in your pulmonary embolism patients. Because in these patients, if your patient is not hypotensive, my initial vasopressor would be vasopressin, because like I said, it's the only pressor that wouldn't further constrict your lungs. It only works peripherally. But it doesn't really increase your blood pressure. So in our patient, she was hypotensive. So she also needed the help with blood pressure. And so that's why norepinephrine was a better first choice, because that also increases your blood pressure. But yes, these are the conversations that we have when the patient arrives.
And another information, practice information, about resuscitation, yes, resuscitation. What is the specific role of the pharmacist?
Sure. So the question was about resuscitation. So as soon as the patient lost her blood pressure and started what we call coding, we have this kind of rolly bin that we call our code cart, and it has different drawers in it for different supplies. So the first drawer is our medication drawer, and it has all of our resuscitation medications in it. So it has epinephrine, lidocaine, atropine, calcium, magnesium, and so we are the ones that manage that drawer. And so we know that every 3 to 5 minutes we're going to give the patient epinephrine, so we always have one ready. And then say we didn't know the patient had a pulmonary embolism, but it was suspected, we would talk about, do we want to give a thrombolytic? Do we want to give alteplase? Because we think this patient is arresting due to a clot. And so we would talk about that. We would then go get the medication, prepare it at bedside, and give it. So we're, again, involved in the treatment discussions, but also in grabbing the medications.
This is very important. I'm happy because our students know very well something about ketamine. Ketamine is very important. It's one of these up-to-date drug used in some emergency department. In Italy, only few departments. And so the point is that probably students in counseling are more used to know or know more about ketamine than students in medicine.
Mm-hmm.
In USA is more
Ketamine? Oh yeah, we use ketamine a lot. We use a lot for procedure.
We use it nasal
Mm-hmm.
yes, by nasal.
Nasally, we typically will use it for children. Yes, we do use it intranasally, particularly in our pediatric patients. With an atomizer? Mm-hmm.
Because we try to use, to experiment these activities, not that we try, but experiment the method in specific practical laboratories.
Mm-hmm. Yes,
for pharmacists and not for doctors.
Any other questions? Anything from home?
In USA, the pharmacist is working on the patients or near the patients?
Not on. So we're not like doing compressions. We typically are standing at the end of the bed. All right, moving on to our last case.
Scrivo io, qualcuno parli?
Should I keep going? All right, moving on to our last case. So this is an alcohol withdrawal case. It is a 46-year-old male. He presented to the emergency department complaining of headache, nausea. He was vomiting. It was non-bloody. He was restless, and he had a concern that he potentially had a seizure. He woke up on the ground. He didn't know why he was there. He states that he typically drinks about 1 gallon of vodka per day, but has not drank in about 10 hours because he was planning to admit himself to an addiction treatment program, so he wanted to give himself a period of sobriety before getting there. So what sort of scale do you guys use in Italy to determine the severity of alcohol withdrawal? So I think globally, the most common scale is the CWA scale. Sometimes it's not as, what's the word? It can vary based on the nurses that are administering the scale. It was created for the outpatient setting where patients could actually accurately answer the questions. So it's very much more subjective than objective, but it's still the scale that we are typically using. So how would you initially treat this patient? It sounds like they're in pretty moderate to severe alcohol withdrawal and likely need treatment quickly because they potentially already had a seizure. You could get a blood test. Would you be looking for like an alcohol level? What would you be looking for in the blood test? No, that's okay. So we will often typically start medication on the patients before we get any of their laboratories back. So the first medication we would typically give them is a benzodiazepine at Mass General. It's usually the lorazepam. So when we think about the pathophysiology of alcohol withdrawal, we know that when patients drink, alcohol binds at what's the GABA receptor. And so when you chronically drink alcohol, this chronic stimulation of the GABA receptor leads to receptors actually going away. So patients have less GABA receptors in their body with chronic alcohol use. But there's another receptor called the NMDA receptor that the alcohol actually inhibits. And so with chronic use of alcohol, you get more NMDA receptors. And so when you stop drinking, you have less GABA receptors and more of these NMDA receptors that aren't being inhibited. And so glutamate binds the NMDA, and that's your excitatory neuron. And that's why your patients present tachycardic, they have tremors, they're usually sweating, because you have all of this glutamate activity and less GABA, because GABA is what inhibits everything. So less inhibition, more excitation, and that's what creates your symptoms of alcohol withdrawal. And so that's why we typically will start with benzos, so that we can increase that inhibition of alcohol withdrawal. And so we will typically, long-acting benzodiazepines are recommended, so more of the diazepam or chlordiazepoxide if your patient can take oral medication. These are just the examples of the routes. As you can see, lorazepam and diazepam can be given at very different routes, different starting doses. Lorazepam typically has a faster onset, but diazepam lasts longer because it has an active metabolite. And so that's why many hospitals will use diazepam, because you have to dose it less frequently and it will last longer, but these are all options. And so your patient was given 20 milligrams of diazepam, it's supposed to say every 20 minutes, times 2, with little improvement. So the provider increased the diazepam to 40 milligrams every 30 minutes. After 2 hours of treatment, the patient got a total of 120 milligrams of diazepam, and then started experiencing worsening hallucinations and tachycardia. So that's a lot of diazepam. It doesn't seem to be effective for your patient. So the provider says, what is going on? This benzodiazepine should be working, it's not. I'm worried that the patient is going to seize. They're having hallucinations. What should I do next? So you know that some patients experience benzodiazepine-resistant alcohol withdrawal. And so why do patients experience this? So you know this because you're a pharmacist and you know about the GABA receptor. So when we look at the GABA receptor, we have the extracellular space and the intracellular space. So your actual GABA molecule binds between the alpha and beta subunits at the GABA binding site. Benzodiazepines don't bind there. They bind at a different subunit on the extracellular space. What benzodiazepines do is just make your own GABA more likely to bind. However, as we talked about, with chronic alcohol use, you have less GABA in your body. And so this is why benzodiazepines might not be effective for your chronic alcohol users. But being a pharmacist, you know that barbiturates are different. They bind at the transmembrane spot on the GABA binding site. So they can actually activate the GABA receptor without your endogenous GABA. So they can be more effective for your patients who are resistant to benzodiazepines. So we talked about that. So the provider's like, wow, that's really interesting information. Thanks for telling me that. Let's give them phenobarbital. You say, I agree. And so there's different dosing strategies how we give the phenobarbital. We can either do the 260 and the 130 kind of mini boluses, or we can do a large loading dose of the 10 milligrams per kilogram. So you discuss all of these different kind of dosing strategies with your patient. And he says, okay, well, what would you recommend? You say, well, our patient already got 120 milligrams of diazepam in the last couple hours. That's a lot of benzo. And because both your phenobarbital and your benzo bind the GABA receptor, they do have synergistic effects. And so your patient might become over-sedated if you give them too much phenobarbital. So you say, and this is part of our treatment pathway as well. So you say, okay, well, why don't we start with 130 milligram small dose and reassess our patient every 30 minutes, and we can just give little doses until it is effective. So you ended up giving a few of the little doses over the next 3 days, and by day 4, his tremors, his hallucinations, and his tachycardia resolved. And that's the end of the case. So again, your knowledge about pharmacotherapy, how different medications bind to different receptors, helped you recommend a more appropriate treatment strategy for your patient. Thank you. Questions?
I have a question, but maybe because I have not a lot of knowledge about that. But for what I know, if a person is, if a patient is administrate benzodiazepine, There is not any possibility that you are given medicine and that person is, I don't know how to say that, is getting worse and worse and worse because they are interaction between alcohol and drink with the vendor?
Yes, so that's a very good question. So the question is, the patient obviously drinks a lot of alcohol, and so they might still have alcohol in their body. And so you're giving the benzodiazepine on top of the alcohol. Are they getting worse because of the combination? So we have to think about the mechanism of the alcohol, right? So we know that alcohol binds the GABA receptor and is a CNS depressant, just like your benzo. And so if they were adding on to each other, what you would expect to see is more somnolence, the patient potentially becoming unresponsive, but this patient was becoming more agitated, tachycardic, and so they were kind of going the other way. So that's something that, it's a good question, and you would just kind of have to think about the different mechanisms of the different drugs, which you would be able to do as the pharmacist. So likely not due to the combination, but that is a good question.
Sorry, I'm curious about how many hours per day do you work?
Well, I'm paid to work 8 hours a day. But I just love what I do. So I do a lot of my writing of papers and committee work outside of work, just because you are so busy when you're physically in the emergency department. But the good thing, we actually do have dedicated administrative time. So about 1 day every other week, I'm not working clinically, and I have an administrative day to take care of all of my tasks, or my indirect patient care activities that I need to do.
Another question, the pharmacy school and the residency is necessary only for clinical pharmacists or all type of pharmacists?
That's a good question. So our retail pharmacists, that would be like the equivalent of your pharmacy pharmacists, they are starting to have residency training programs. However, the programs are, the kind of end goal is so they could be a manager of the pharmacy, not just kind of work at the pharmacy, but be a manager in the end. And so there are retail residency programs. The programs that I talked about, you typically you would work in the hospital or you would work in that physician clinic. Any questions from home? Perfect. Well, thank you all. Even if you didn't understand the clinical cases, everything I said, I hope I just kind of showed you where a pharmacist comes into play, how they can be helpful at the bedside in optimizing the patient medication and kind of the interaction with the medical team. Thank you.
Okay, if we don't have any other questions or comments, also from people online, we stop now this session. The appointment is for tomorrow at 5:30 p.m. and then on Thursday at 10 o'clock a.m. Thank you very much. Non mi ricordo più.
The development of the new National Health Service requires commitment and training. Knowledge and organization must be adapted to the needs and modernized. Scientific and technological development, from advances in molecular or imaging diagnostics to the rapid development of new drugs, instrumentation, and methods, from the perspectives of regenerative medicine to the spread of wearable monitoring tools, designs medicine in continuous evolution with the patient at the center who is increasingly involved in his own personalized healthcare process. As a result, the health organization is also evolving toward new models of care, integrating the different specialist skills and services with respect to the clinical conditions of the acute and chronic phases of the disease in an aging population that presents increasingly complex problems. We are therefore faced with new types of therapeutic strategies and with an organizational evolution, both nationally and regionally, that needs to evolve the model of clinical pharmacy currently applied in our NHS. The clinical pharmacy was born from the need to customize the therapy and the approach oriented to the individual patient and his needs. Now is the time to rethink and modernize this approach, providing a more marked involvement in the clinical part to get fully into the new model of care as competent and organized specialists. The clinical pharmacy can develop into a new model of care if it offers professionals and prepared both from a technical and managerial point of view. We will have the excellent opportunity to hear from the protagonists at the forefront of this new service for Italy, which is the collaboration doctors and clinical pharmacists. From USA, Chicago and Harvard, Lexi Osrow and Jenny Cowell will talk about seniors in ED and collaboration in clinical pharmacy.